Adolescence module. Thank you very much. Thank you.
Hello. Thank you, Dr. Samir. I think it is very difficult to sum up what you have said, because what you have said is actually your personal experience. I think for the last 15 years I had been hearing the same presentation, but it had evolved
I think for the last 15 years I had been hearing the same presentation, but it had evolved. I think for the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
For the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
For the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
For the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
For the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
For the last 15 years I had been hearing the same presentation, but it had evolved.
All these things.
Good afternoon, everyone. After such an insightful and informative lecture of Dr. Sanjeev sir, we move forward for the next lecture by a senior pediatrician from we move forward for the next lecture by a senior pediatrician from we move forward for the next lecture by a senior pediatrician from we move forward for the next lecture by a senior pediatrician from
spend half an hour with you on a topic which is extremely common with all of us. Now, actually speaking, what happens is I was given a topic of does my child really require MDI? म्हणजे खरंच तू लिहायला तुमची गरज आहे का? सगळेजण वैतागले होते तीन रिजेक्टच करतात. आपलं नेब्युलायझर खूप छान चालतं आणि that's what we try to do, and I'm really going to exactly tell you what is my experience doing, children with recurrent respiratory symptoms, a few of them are medical, and how do you manage in your practice. So my aim today is not to deliver a module, because I think everybody has attended modules. N number of them, ATM, Casper, I've done everywhere, across. But I feel nothing really comes into practice. But how you get guidelines into practice is really I've worded this, कुछ खास बातें खासी की. And this is an entirely practical way of looking at patients who come to us in our clinics.
लावरे लवकर लावरे.
Hello? So this is how I thought that I should be. Hello? So this is how I thought that I should be. Hello? So this is how I thought that I should be. Hello? So this is how I thought that I should be. Hello? So this is how I thought that I should be. spacer and not with nebulization. आपण काय सर्व करत होतो, सगळं वाफ आपण ब्युडेसोनाइड वापरून हा खोकला घालवायचा प्रयत्न करत होतो. Now does my child really need importance? Now this is the commonest symptom. It's very distressing. आई वडील वैतागतात की कुठल्याही डॉक्टरना माझ्या खोकला बरा करून देता येत नाही. आपल्यालाही वाईट वाटायला लागलं की अरे आपण इतके वर्ष प्रॅक्टिस करतो, हा खोकला साधा का बरा होत नाही. आणि इतकी मॉड्युल्स आपण अटेंड केली आहेत, पण नन ऑफ देम सीम टू बी रिअली वर्किंग. नंतर दुसरं काय, खोकल्याचं कुठलं औषध डझंट रिअली वर्क. प्रत्येकजण काय सांगतो, डेक्स्ट्रोमेथोफेन द्यायचं नाही, लेवोक्रोपासिन नॉट इंडिकेटेड इन प्रॅक्टिस, अँटीबायोटिक देऊन थकतो आपण. नेब्युलायझरचे जे मशीनंसुद्धा थकून जातात, इतकं वाफ देतो आपण आणि पेशंट बरेच होत नाहीत. पण MDI वापरायचं म्हटलं की आपल्याला काय भीती वाटते की मी हे जर सांगितलं ना पेशंटला, तर पेशंटला वाटेल हा दमाय माझ्या बाळाला, तो पीडियाट्रिशियनच बदलेल, तो म्हणेल ह्याची सवय होईल, दिस इज स्टिरॉइड, दिस इज ॲडिक्टिंग अँड सो मेनी थिंग्स. दॅट्स वाय वी डू नॉट जनरली think of introducing meteorology in here when it is to be actually introduced in a few patients at least. My aim is practical approach, guidelines into practice, and what are the pitfalls in the management. Now the most important thing all of us should understand, we have to give more time than prescription. आपण काय करतो, पटापट लिहित असतो पेशंटचं, खूप औषधं लिहितो आणि then we don't speak and talk to them, and that's the way mistake that we generally make. And counseling, remember, is the backbone of management. आता कसं बोलायचं आणि आपण कसं बोलायला पाहिजे, निदान मला जो वाटतं म्हणजे व्हॉट आय थिंक वर्क्स इज व्हॉट आय एम गोइंग टू शेअर विथ यू. काउन्सिलिंगमध्ये पहिल्यांदा सांगितलं मेंटेन अ सिम्पटम डायरी. तुमच्या पेशंटचा खरंच खोकला कधी जास्त आहे, नॉक्टर्नल, डायुरिनल, ट्रिगर इंड्यूस, मल्टी ट्रिगर व्हिजर्स आहेत, किंवा त्याला ताप असतो का नाही. व्हिडिओ रेकॉर्डिंग इज अगेन व्हेरी इम्पॉर्टंट. कधी खोकतो तो आणि कसा खोकतो ते पण बघू. टेम्परेचर चार्ट, प्रत्येक आई हे डोक्याला हात देऊन काय सांगते, माझ्या बाळाला ताप आहे. आणि ताप म्हटलं की आपण काय करतो, अँटीबायोटिक देतोच, कारण आपल्याला भीती वाटते, लेट्स बी सेफ. आणि डॉक्टर्स पण बदलत राहतात सारखे पेशंट. त्यांना म्हणायचं तुम्ही डॉक्टर बदलता ना, नुकसान तुमचं आहे, कारण कोणत्याही डॉक्टरचा सखोल अभ्यास होत नाही आणि त्याच्यामुळे नो बडी रिअली कम्स टू द डायग्नोसिस ऑफ दी कॉफ दॅट यू आर ट्रीटिंग विथ सो मच ऑफ फ्रस्ट्रेशन. आणि सगळ्यांना सारखं वाटतं की मी एक्सरे काढतो, रक्त तपासू, हे करू ते करू, आणि इन्व्हेस्टिगेशन डू नॉट ट्रीट, दे ओनली हेल्प यू. सो दिस इज अगेन व्हेरी इम्पॉर्टंट. चेक दी कॉम्प्लायन्स ॲडिहरन्स. आपण कधीही आपण लिहून दिलं ना की फक्त काय करतो, हे घ्या तुम्ही तुमचं द्या. डज ही रिअली नो हाऊ टू गिव्ह इट, टेक्निक each time and every time. This is again very important. So take the symptom diary, write on the left side of the prescription your findings, and do this each time and every time. So compliance adherence has to be treated, and tell them की हा 6 आठवड्याचा खोकला बरोबर करून द्यायला कमीत कमी 6 दिवस तरी द्या. Patients want you to be a magician and not a clinician. You please tell them in time, and tell them green flag signs. तुमच्या बाळाचा वजन वाढतंय, खेळतोय दिवसभर चांगला असतो, रात्रीच फक्त खोकते, ग्रीन फ्लॅग साईन. अँड टू मेनी मेडिसिन्स डू नॉट वर्क. आपल्याला मुलं काय सांगतात, मी एक औषध घेईन, दुसरं घेईन, आणि तिसरं गेलं तर सगळंच उलटी करेल. सो प्लीज डू नॉट गिव्ह टू मेनी मेडिसिन्स टू दी चिल्ड्रन. यू नो दिस इज द ट्रॅजेक्टरी ऑफ कॉफ दॅट ऑल ऑफ अस मस्ट नो. मोस्ट ऑफ अस सी द ग्रीन लाईन. म्हणजे काय, पहिले 2-3 आठवड्यांनी खोकला हळूहळू कमी होतो, आणि हा जो खोकला कमी होणार असतो ना, हा खोकला जो ग्रीन लाईन खालती यायला लागते, ती ग्रीन लवकर कधी येते, इफ यू यूज दी इनहेल कॉर्टिकोस्टेरॉइड्स. देन द ब्लू लाईन दॅट यू सी, दॅट जातो परत येतो, जातो परत येतो. These are recurrent episodes of cough which are highly suggestive of reactive airway disease. And the last one which is rarely seen is the red one. त्याच्यामध्ये काय होतं, it is increasingly persistent cough, and we see this in patients with foreign body pertussis or tuberculosis. So try and find out which line does your child really follow. So most of them it is the green line that is most common. A few of them have the blue line, and the last one is the red one. What I am trying to tell you is the green line, if you start using inhale corticosteroid, that is what this, the green line comes down a little faster. They are not asthmatic patients, please remember. And when you give steroids to this patient, inhaled, not oral, they would recover a little faster. Instead of taking 4 long weeks, they would probably get all right within a week or 2. So this is the green, this is the red, and this is the blue that you should know. Then about cough. When there is cough, the louder the cough, the higher it is situated. So when there is much of cough, laryngitis, you get barking cough. So when there is significant cough, please remember there is airway disease, and when there is significant fever, there is parenchymal disease. So no fever, mild fever, no chest pain, no activity limitation. Remember, it may be an airway disease, but a patient with sick looking, chest pain, mild cough, taap jasti, khokla kami, that means that patient has probably got parenchymal disease. These are not watertight compartments. But you can try to find out what is the correct thing. And then remember, when the patient has a recurrent, parat खोकला होतोय, खूप जास्त असतो, रात्रभर खोकतो, दिवस चांगला असतो, व्हेरिएबल, ट्रिगर इंड्युस्ड, हवामान बदललं, गारमट खाल्लं, लगेच खोकला होतो. व्हायरल इन्फेक्शन इज द कॉमनेस्ट ट्रिगर, रात्रभर खोकतो. सो रिमेंबर दिस adjectives of cough will always tell you that you are dealing with a patient who probably requires inhalation therapy. Activity induced, जी मुलं काय म्हणतात, तो हसला की खोकतो, नॉर्मल मुलं खोकत नाहीत, रडला की खोकतो, आणि खूप खेळला दुसऱ्या मुलांबरोबर दमेपर्यंत, तो दमल्यावर नॉर्मल मुलं खोकत नाहीत, पण हा नक्की खोकतो. सो दिस इज व्हॉट यू नीड टू नो. अँड पर्टिक्युलर इन पेशंट्स हू हॅव एन अस्थमा प्रोटेक्टिव्ह इंडेक्स, दॅट API पॉझिटिव्ह, म्हणजे आई वडिलांना सुद्धा ॲलर्जिक रायनायटिस आहे, दमा आहे, आमच्या घरी दम्याचे आले, जे चाइल्ड हॅज गॉट एटोपिक डर्मटायटिस, such an atopic family. Now these are the patients who are probably likely to have troublesome cough suggestive of reactive airway disease. Now the nature of cough can also decide. Lower airways मध्ये wet cough असतो. Whenever there is wet cough, you probably require antibiotics. And lower larger airways मध्ये you will find that the cough is more than tachypnea. But classically, in lower smaller airways like bronchiolitis, you will find a child with bronchiolitis coming, well looking, खेळतात, पण खूप tachypnea असतो, and that is lower smaller airways. So try to find out, take the detailed history and try to find out the localization of respiratory disease. This is the asthma predictive index, all of you know. So whenever a patient has physician diagnosed asthma in the parents, allergic rhinitis in them, atopic family and food allergy, remember your asthma predictive index is positive, and these children do not recover fast. That's the green line that I showed you. It does not come down very fast, and that is where they take as long as 3 to 4 weeks to recover or come back to normal even after a minor viral infection. So it's not a one-point diagnosis. As I told you, symptom diary analysis is very important. No polytherapy. रिस्पॉन्स टू ट्रीटमेंट टेल्स यू की ह्याला अँटीबायोटिकचा उपयोग होतच नाही, ह्याला फक्त आपण साल्बिटमॉल दिले की फरक पडतो. आणि त्याच्यासाठी तुम्ही यू हॅव टू डू अ सखोल अभ्यास. म्हणजे काय, ॲनालाइज द सिम्पटम डायरी, सी द रिस्पॉन्स टू ट्रीटमेंट अँड डिव्हॉल्व्स ओव्हर अ पिरियड ऑफ टाईम. मी पेशंटला काय सांगतो की तुमच्या बाळाचा परत परत होते तर त्याचा सखोल अभ्यास करणं फार गरजेचं आहे. आणि जेव्हा खोकला जाईल आणि परत येणार नाही, तेव्हाच मी तुमच्या वेळेला बरं करून सांगतो काय नक्की झालं होतं. नाउ व्हॉट इज इम्पॉर्टंट फॉर ऑल ऑफ अस टू नो इज, दिस इज अ स्मॉल, यू कॅन से slide, which is an academic slide. Now what we do is, when the patients come to us, say जे bumps दिसतात ना, bumps, hey, this is when the patient comes to us. आणि ह्यांना आपण वाफ देतो, साल्बिटमॉल देतो आणि बरं करून देतो. पण what we are not treating is the chronic inflammation. What you see this. Now this chronic inflammation is ongoing in children who are atopic families and from patients whose parents have also got asthma. So ती green line जी खालती लवकर येत नाही, ती कधी होते, when patients have this ongoing. That is where your inhaled corticosteroids are very useful. Please remember, this inhaled corticosteroids had to be given with meter dose inhaler and spacer. ते पण मी सांगतो का द्यायचं असतं. Now all of you know this. This is the पर्सनॅलिटी डिसऑर्डर ऑफ द. मी आई वडिलांना कसं सांगत, ह्याच्या बाळाचा त्याचा फुफ्फुस रागीट आहे. राग आल्यानंतर काय होतं, काही जण कसे गप्प बसतात, 2 दिवसात राग विसरून जातात. पण ह्याला सर्दी झाली आणि खोकला झाला की त्याचं फुफ्फुस एवढं रागीट असतं ना की तो 3-3 आठवडे त्याचा राग जात नाही. मग रागीट माणसाचं काय करतो आपण, शांती करतो ना. आणि शांती करण्यासाठी त्याला आपल्याला इनहेल कॉर्टिकोस्टेरॉइड द्यायचं आहे. पण ते किती 2-4-8 दिवस 15 दिवस नेब्युलायझरनी नाही, पण त्याला कदाचित मीटर डोस इन्हेलरनी स्पेसरनी टायट्रेट करून द्यायला लागतं. नाव रिमेंबर विथ नेब्युलायझेशन यू कॅनॉट टायट्रेट द डोस ऑफ ब्युरेकॉट. So that is what you try to tell them. So how much time you have to spend talking to parents is again very, very important. अस्थमाचं कसं माहिती आहे का, आपल्याकडे हे जे पेशंट आहेत ते कोणी डायग्नोज करतात, म्हणजे आपल्याकडे मावशी आयासुद्धा हे डायग्नोज करतात. बट व्हॉट इज रिअली इम्पॉर्टंट इज टू डायग्नोज दीज पेशंट्स हू आर ॲडमिटेड विथ रिकरंट न्युमोनियाज. मला दर 2-3 महिन्यांनी न्युमोनियासाठी ॲडमिट करतो, त्याचा खोकलाच बरा होत नाही, प्रत्येक वेळी छातीत कफ आहे आणि अँटीबायोटिक देऊन सी दीज आर द पेशंट. नाव रिमेंबर दिस इज वेअर रिकरंट नॉक्टर्नल मल्टीट्रिगर इंड्यूस कॉफ यू शुड थिंक ऑफ एन अस्थमा. आपल्याला काय वाटतं दमा म्हणजे फक्त दम लागला पाहिजे. इट इज नॉट. अ कॉफ दॅट इज डिफिकल्ट टू ट्रीट विच इज रिकरंट नॉक्टर्नल ट्रिगर इंड्यूस कॅन ऑल्सो बी द फर्स्ट अँड द ओनली सिम्पटम ऑफ अंडरलाइंग अस्थमा. नाव दिस अस्थमा इन चिल्ड्रन कॅन बी व्हेरी ट्रान्झियंट. 5 वर्षांनंतर मुलं बरी होतात and they don't require long-term treatment and they don't have asthma. Now this is a very, very important slide. All of you have seen this slide at various ATMs and even in Caspers. You know, most of the patients do have more than 3 to 4 episodes of cough in, most of them. But ज्यांना interval symptoms नसतात आणि ज्यांना पटकन बरे होतात त्यांना very few have asthma. Now don't tell these patients you have asthma. त्यांना इन्हेलर समजावून सांगायचं की आपण साल्बिटमॉल देतोय पण फक्त औषध छातीत सोडण्यासाठी देतोय. तुम्ही जे औषध पाजता ते पोटात जाऊन छातीत जायला वेळ लागतो. म्हणजे यू आर गोइंग टू दिल्ली बाय ट्रेन. मी जे इन्हेलर देतोय ते काय होतं आहे एक्झॅक्टली डायरेक्टली छातीत जातं आहे. म्हणजे यू आर गोइंग बाय फ्लाईट फ्रॉम से पुणे टू दिल्ली आणि त्यांनी पटकन तुम्ही पोचता. इट शुअरली गोज इन साईड. सो दॅट इज व्हॉट इज इम्पॉर्टंट. In the second, what is happening? It is taking a long time, म्हणजे ते green line. Then they have interval symptoms and these are the patients who probably require inhaled corticosteroid to hasten their defervescence of illness. If it happens again and again, you need to give them a trial of controller therapy. This is what is the trial. Now, ही trial of controller therapy किती दिवस आहे? 3 months. आपण काय करतो एक 10-15 दिवसच त्यांना इनहेल कॉर्टिकोस्टेरॉइड नेब्युलायझेशनने देतो. एक तर त्याचा डोस बरोबर जात नाही आणि 3 महिने दिल्याशिवाय त्याचा तो रागीट स्वभावाची शांती पूर्ण होत नाही आणि इथेच पेशंट 3 महिने न दिल्यामुळे ते प्रॉब्लेम परत होतात. बट इन दोज पेशंट्स हू कम have an atopy and do not get all that or come with an acute exacerbation, R is probably in the box 3. Now remember, these are all interchangeable boxes. They are not watertight compartments. So it's very important for us to know that these are all, they can shift from the first box to the second and the third box. And the other way also can happen. From the third they come to the second and the first box. म्हणूनच आपण म्हणतो ना की 5 वर्षांनंतर तुमची मुलं नॉर्मल होतील. Now, which is the best inhalation device? All of you know this. With nebulizer, only 10% or 5% will go. But with meter-dose inhaler and spacer, the amount of drug that goes into the lungs is more than 20-25%. So this is very important for us to understand that you have to give inhaled medicines, not with nebulization. 2 main things. You cannot titrate the dose and you cannot give inhaled corticosteroids for 3 months with nebulizer. What is the most important thing to prevent recurrence? You have to give it for 3 months. Now remember, many patients only require treatment for 3 months. They are not asthmatics at all. They are in the first or the second inhaler spacer. पण ह्याच्यामध्ये प्रॉब्लेम आपल्याला रक्ताचं पाणी करून औषधात टेक्निक समजावून सांगायला लागतं आणि पेशंटनी रेग्युलरली येऊन ते ॲडिअर करायला लागतं. मोस्ट ऑफ देम डोंट डू इट. आपण जसं परीक्षा संपल्यावर अभ्यास बंद करतो, आई वडील काय करतात, खोकला संपला की ब्युडेकॉट बंद आणि मग ते होत नाही. म्हणून सांगतानाच कसं सांगायचं, यू शुड ओनली गिव्ह इट टू पेशंट्स हू विल कॉम्प्लाय विथ द ट्रीटमेंट फॉर 3 months. आणि हे कुठे पेशंट करतात माहिती आहे? दोज फॉर ॲडमिटेड विथ सिव्हिअर एक्झर्सर्बेशन. ते मात्र नक्की वाईट अनुभव आल्यामुळे गिव्ह इट फॉर 3 months. सो त्यांना सांगायचं रागीट स्वभाव शांत करण्यासाठी 3 महिने द्यायचं आहे. डिंकासारखा चिकटलेला कफ पातळ करण्यासाठी मी इनहेल कॉर्टिकोस्टेरॉइड त्याला दमा नाही आहे असं सांगायचं. आणि इनहेल कॉर्टिकोस्टेरॉइड गेल्यामुळे तो डिंकासारखा चिकटलेला कफ आहे, तो जास्त रागीट स्वभाव फुफ्फुसाचा, ते शांती करण्यासाठी मला 3 आठवडे ट्रीटमेंट द्यायला लागेल. और 3 महिने ट्रीटमेंट द्यावं लागेल. विमानाचा प्रवास डायरेक्टली युअर गोईंग आणि पहिल्या दिवशी इन्हेलर घेतच नाहीत मुलं. जसं पहिल्या दिवशी मुलं शाळेत जात नाहीत, तुम्हाला पहिल्या दिवशी गाडी चालवायला येत नाही, पण तुम्ही चिकाटी जिद्द म्हणजे कष्ट, जिद्द आणि चिकाटी दाखवली तरच ते इन्हेलेशन थेरपी 3 महिने दिले तरच हा खोकला परत परत होणार नाही. हे आवर्जून परत परत पेशंटला सांगायला पाहिजे. डॉक्टर सारखे बदलले की अभ्यास सखोल होत नाही. युअर इन्हेलर Asthalin or salbutamol is only for relief of symptoms, that is bumps that I showed you. पण जेव्हा तो परत परत होतोय क्रॉनिक इन्फ्लमेशनसाठी इनहेल कॉर्टिकोस्टेरॉइड्स विथ मीटर very important. So whenever you see patients like this, remember many of them are usually in the first and the second box. First आणि सेकंड बॉक्समध्ये जे पेशंट्स आहेत त्यांना फक्त इनहेल कॉर्टिकोस्टेरॉइड बिलो 5 years देतो. ते फक्त ट्रायल ऑफ कंट्रोलर थेरपी. दे आर नॉट अस्थमॅटिक्स अँड मोस्ट ऑफ देम डू नॉट हॅव अस्थमा. अँड इफ यू स्टील वॉन्ट Now, smart therapy is to be used only after 5-6 years of age. What is smart therapy? That is signal maintenance and reliever therapy. And it is also called as MANT, maintenance and reliever therapy. See now that we use a combination of formoterol plus fluticasone, okay, or formoterol plus budesonide. That's what is there. One inhaler is easy for the patient to use it. So what they do is, whenever the patient has your diagnosed asthmatic child, who has an abnormal spirometry and also has been diagnosed with breathometer monitoring. If you use the same inhaler to relieve the symptoms, you can use the same, because formoterol is a quick acting bronchodilator and also helps budesonide reduce load as a controller therapy. म्हणून ते वापरणं सोपं जातं पेशंटला. What you have to do is, remember, you can use it up to a limit. For example, from 6 months or plus 6 years to 11, you can at the most use 48 milligrams of micrograms of formoterol, which is 8 puffs. But 8 puffs पेक्षा जास्त जे 24 तासात दिलं, that means your child is not well controlled, then you have to use salbutamol. But in children above 11 years, you can use up to 72, that is 12 puffs, because every puff has got 6 micrograms. म्हणजे 8 puffs below 11 years and 12 puffs after 12 years of age. But suppose you find that the requirement is more, then you probably have to use salbutamol. Below 6 years, you cannot use it. See, formoterol is not recommended for children. Which one? No, we cannot use formoterol in children below 5 years of age. Aerocod. आता aerocod कधी वापरायचा? See, you know that we do not use only salbutamol in children over 5 years of age, because it is known to have tachyphylaxis and severe exacerbations of that. In 5 years of age, we use only aspirin, that is a recommendation. But मी स्वतः practice मध्ये aerocod वापरतो. I'll tell you why. Especially in patients who have asthma index positive. आपल्या त्यांच्या मोठ्या मुलाला आपण डायग्नोज केलेला आहे. हा छोटा मुलगा आलेला आहे. They have an atopy family. That chronic inflammation has already started. And in these patients, if you give only salbutamol, don't need to tolerate. These are the patients whose that green line doesn't come back to normal. And if you use beclomethasone along with salbutamol, which is there in aerocod, definitely the effervescence is faster. पण एक लक्षात ठेवायचं, सारखं aerocod वापरायला लागतं आणि त्याचे कॅनेस्टर संपतात. म्हणजे काय? He's in box 3, which means then you have to give him a Budecort 100, 1 puff morning for 3 months. Adherence technique check करायचं and then shift from aerocod to aspirin. म्हणजे तुम्हाला एकदा लक्षात आलं की हा बरोबर Budecort व्यवस्थित 3 महिने वापरतोय. That means he is compliant with the technique and adherence of controller therapy, which is a trial of controller therapy. Again, remember this, we have not diagnosed him as asthmatic. So don't tell them your child is asthma. नाही तर ते एकदम तुमच्याकडे येतच नाही. ते म्हणतात ते सगळ्यांनाच अस्थमा आहे असं सांगतात. मी त्यांना नेहमी सांगतो हे फक्त औषध छातीत सोडण्यासाठी वापरतोय. त्याच्या फुफ्फुसाचा स्वभाव रागीट आहे. मोठा झाल्यावर तो रागीट स्वभाव जाईल. बरोबर आहे ना? आपण शांती करते. You keep on telling this, they will definitely do it. But when you have put the child on 3 months of budesonide 100 morning evening, the child is compliant with technique and adherence. Don't give aerocod. Then you are giving too much of steroids. Then you give only aspirin. But in selected patients who have a positive asthma predictive index, and remember, many of them only require a few days. आपला अनुभव बघा ना की 5 वर्षानंतर बरेच पेशंट बरे होतात. पण हा रागीट स्वभाव जात नाही बरं का. You'll find some patients we have seen below 5 years of age come at 12 years of age. They come with a very bad cough. You do their spirometry is abnormal. That means what? त्यांना खरं दमा असतो पण इतके माइल्ड सिम्पटम्स आणि कधी कधी एकदम एक्झासर्बेशन मध्ये येतात. So I think it's very important to do spirometry in these patients and show that it is normal, especially with a family history which is positive. I think I've answered your question. Sure?
Ajay Shastri sir, kindly sum up the session.
Hello. To summarize this huge informative session, I think it would become a CME itself by itself.
No, it is a CME by itself, but I try to just share my experiences, how to talk to a patient, that,
yes, sir.
Or how to counsel the patient.
I think सरांनी आपल्याला हे सांगितलं की सरांनी आपलं काउन्सिलिंग केलं की पेशंटचं काउन्सिलिंग कसं करायला पाहिजे. सरांचं मी पहिल्यांदा टॉक ऐकलं होतं. जळगावला सर आले होते, कॅस्पर मॉडेल झालं होतं आणि आय स्टील यूज द सेम मॉडॅलिटी ऑफ काउन्सिलिंग टू द पेशंट. सरांनी सांगितलं की मी पेशंटचं काउन्सिलिंग तिथून सुरू करतो की बाबा तू काही माझी थेरपी काही घेणार नाही आहे, त्याच्यामुळे मी काही तुला ट्रीटमेंट देणार नाही आहे आणि तू बाहेर जाशील आणि तुला फरक पडत नाही म्हणून बाहेर जाऊन सांगशील की माझा ह्या डॉक्टरने माझा काही आजार बरा केला नाही, त्याच्यामुळे मी तुला काही ट्रीटमेंट देणार नाही आहे. आणि गेट कन्व्हिन्स फ्रॉम द पेशंट दॅट ही इज गोइंग टू फॉलो माय ट्रीटमेंट गाईडलाईन्स, की कमीत कमी 3 महिने मी MDI घेणारच आहे, तेव्हाच मी तुला ट्रीटमेंट देणार. आणि ते जेव्हा कन्व्हिन्स होतील तेव्हाच ट्रीटमेंट चालू करायची. अँड आय आय एम व्हेरी हॅपी टू से की मी हे सगळे सरांनी सांगितलेले काउन्सिलिंग्स मी फॉलो केलेले आहेत आणि 99% ऑफ देम आय वर्कड आउट. 1% लिव्हरेज आय वुड गिव्ह, not in delivering the time which I could. So the nutshell is counseling of the pediatricians have been done in this talk. Now the counseling of the patient is remaining, that we can do easily by following Deknesar's content.
I'll take a minute. You know what example I told in Jalgaon 10 years ago is a little, I mean he has told correctly. मी त्यांना सांगतो नेहमी की तुम्ही एवढे डॉक्टर बदललात ना, आता तुम्ही अजून जाणार असाल दुसरीकडे तर मला नकोच, तुम्हाला ट्रीटमेंटच द्यायची नाही. यू हॅव टू फॉलो मी अँड मी ओनली. मी अशा मुलांना क्लासमध्ये घेतो जी मुलं परीक्षा संपल्यावर सुद्धा अभ्यास करतात. म्हणजे वॉट, तुम्ही खोकला गेल्यावर सुद्धा ट्रीटमेंट चालू ठेवणार असाल तरच मी घेतो, कारण माझ्या क्लासमधली मुलं नापास झाली की माझं नाव खराब होतं. सो आर यू रिअली गोइंग टू बी कॉम्प्लायंट विथ कंट्रोलर थेरपी फॉर 3 months, तरच आपण ट्रीटमेंट चालू करू, नाही तर करायची नाही. मी आता बरा करून देतो. 15 दिवसांनी तुम्ही घराला सगळ्यांना विचारून या, आजी आजोबा सासू वगैरे सगळ्यांना, आणि मी देणारी जी ब्युडेसोनाइट 100 1 पफ मॉर्निंग इव्हनिंग देणार आहे ते 3 महिने तुम्ही खोकला जरासुद्धा नसताना पूर्ण देणार असाल तरच तो खोकला, त्याचा रागीट स्वभाव डिंकासारखा चिकटलेला कफ निघणार आहे. यू थिंक ओव्हर अँड कम, दॅट इज द प्रॉब्लेम. सो डू नॉट सेल कंट्रोलर थेरपी विच इज ब्युडेसोनाइट. लेट द पेशंट बाईट फ्रॉम यू. आणि ते आपणहून येणारे जे पेशंट असतात तेच कॉम्प्लेंट असतात आणि मगच ते पेशंट बरे होतात. थँक्यू सो मच.
Sir has beautifully explained about the GINA guidelines. I would like to refer GINA guidelines up 1 to 6 years, 6 to 11 years, and above 11 years. It is beautifully explained. So just refer the GINA guidelines in the 3 categories.
At the end of this session, I think आपण एक शपथ घेऊया डेक्नेसरांच्या समोर की आपण आपल्या ओपीडीतनं कधी पण बेटनेसोलचे ड्रॉप्स घेऊन 24 पेशंटला बाहेर जाऊ देणार नाही आणि हेल्दी बेबीपेक्षा हेल्दी लंग्स तयार करू. थँक्यू सर.
Thank you, sir.
थँक्यू.
I request Dr. Mahesh Airav sir and Dr. Sachin Dhole sir to kindly felicitate the dignitaries. In every child who is born under no matter what circumstances and of no matter what parents, the potentiality of human race is born again, and in him too once more and of each of us our terrific responsibility towards human life. So the next lecture is very apt to this saying by Dr. James Aggie. Now I would like to request Dr. Om Prakash Jamadar sir to deliver his lecture on preterm feeding and follow-up of NICU graduates. For this, I would like to invite Dr. Anand Deshpande sir from Pune to chair the session and Dr. Sachin Vadne sir from Ahilyanagar to co-chair the session.
Yes, good afternoon, everyone. We are slightly late for proceedings. I thank team IAP from Dhule as well as Maharashtra State IAP and the central IAP dignitaries who are there at the dais. So the session and the topic seems quite common to everyone. Feeding challenges that we face in the NICU graduate as well as the follow-up that we are going to do for the NICU graduate. So my purpose is to have some take-home challenges and take-home messages that everyone can follow in their practices. Does this work? So feeding, all of you are aware of, preterm babies the definition is very clear, less than 37 weeks. But what is the most challenging for all of us is babies who are extremely preterm, those who are born less than 30 weeks of gestation. That is the one situation. And babies who are less than 1 kg. So there is no any sponsorship. I'm going to try to cover the images which will be just for representative purposes. This is the place where I did my undergraduate studies in India, and this is the place where I did my studies in UK, and this is where I'm practicing at the moment. So I will try to cover who are there in the NIC who are we call as graduates, and then what is the goal of preterm feeding, what are the challenges that we face, and then what is the need of follow-up for all these preterm babies in the post-discharge. So graduates are, as we know, we have been to the medical schools and did all these studies, but what we are talking is the graduates who are discharging from the NICUs. So what is the aim of the nutrition? Our aim is to achieve the growth that baby is supposed to happen in utero, and there is no ex utero compromise in the growth. That is what the aim of our nutrition, and for that all of us struggle in the NICU settings, and there will be multiple challenges. We won't be able to feed, we can feed, but not great volumes. What to use, how frequently to give, what is the quantity of feed, that all challenges we are going to try to cover. So when I say challenges in the life, I remember this verse from Bhagavad Gita which was spoken by Lord Krishna. In fact, Arjun asked Krishna, he's saying, Karpanya dosh, confused. Oh Krishna, I'm confused. What I have to do, I don't know. And that is what many times happen in our practices, to give feed or not to give feed. And then that is how we are going to proceed with our session. So this is a preterm baby that everyone is aware of, 26 weeker, very tiny baby, and has got multiple challenges from RDS, surfactant, chronic lung disease, feeding intolerance, and all that things. Every one of us is aware of this story. So this is a situation where we can't feed because being extremely preterm, because being on inotropes, because baby may have got some underlying cardiac diseases or maybe have underlying GI problems where we need to do immediate interventions. So here we can't feed. So what we can do in this situation? We need to think of early parental nutrition. Day one itself is very important for us to decrease the metabolic load on the babies. Otherwise, babies start, losing their proteins, losing their brain mass if you don't give adequate nutrition from the day one. So we have to start protein from day one itself. We can start 2 grams, and then subsequently we can grade up to 3.5 to 4 grams. Lipids we can start from day second, and we need to maintain a normal glycemia. That is very important. But we need to be careful in terms of taking care of aseptic precautions when we are thinking of giving the parental nutrition for all these extremely preterm babies. So once the baby is stabilized, we need to decide what we can do next. So next what we do is starting some trophic feeds. So what is the trophic feed? Anyone is aware of what is trophic feeds? It's a small amount of feed that we give, just 10 ml per kg. And this helps to improve the gut maturation. This improves the digestion capacity of babies, and that everyone is aware of. However, if baby is healthy and fine, we need to look at the suck. So development of the suck is the first thing that happens at 11 to 12 weeks of gestational age, and the swallowing is the subsequent thing to develop. And the maturation of the suck and swallow happens at 32 to 34 weeks, and that is the time when we can think of starting oral feeds. So this is a good flow chart. Babies more than 34 weeks, we can directly go for breastfeeding. Those borderline between 32 to 34 weeks, we can start feeds by palate or spoon, see the responsiveness, see the sucking, and then we can go back to the breastfeeding. But babies who are less than 31 weeks, that baby needs some extra efforts. We may have to go for OGT feeds if the baby is stable, and those babies who are less than 28 weeks, we should think of starting parental nutrition, and we should think of giving stropic feeds for all these babies. So challenges is like, concerning the first question by Arjun, Krishna is saying here, yes, no doubt, there is difficulties there. Asocham anusochasvam prajna vadansh bhashase gata anusugata musam nanu sochanti pandita. Arjun, you are talking of very learned words, but in reality they are not learned words, they are cowardly words. So you should not think of fighting or not fighting, but you should do your responsibility and duties. So what are the challenges to feeds? What to feed is the first and foremost thing. Mother's own mom, that is what we say. There is no doubt about this. And second best option after available, if mother's milk is not available, is the donor human milk. That is the second best option. And you can explain to the parents that the IQ of the baby increases like 5 to 8 points if the baby is getting mother's milk or donor human milk. That gives a positive impact for the mothers to do extra efforts to improve the milk production that she is having. So we know everyone is aware that milk is required, but how to get the milk early, that is one thing, and how to sustain the milk for a longer time. That is the challenge that we face. So this is a very good study where for early expression of the milk helps to improve the early production of the milk. That is what it has shown, and this is what we want everyone to practice in their day-to-day life, so that within 6 hours of delivery of a preterm baby, don't think that milk will come or not come, but we have to start expressing the milk so that the hormonal stimulation happens earlier. And the second part is oropharyngeal application of the colostrum. Any one of you are doing application of colostrum in the oropharyngeal cavity? Can you raise your hands? So there is good evidence that it helps to improve the microbiota, it decreases the inflammatory markers, it decreases chances of early onset as well as late onset sepsis. So this is how it is important to start application of colostrum in the oral cavity. Don't use a gauze piece. That is another thing that I have observed at many places, because that itself absorbs. You can use maybe some clothes where you can coat your fingers, or you can ask the mother. That is the best therapist in this situation, so that there is more bonding with mother and baby. So maintaining breast milk supply, as I said, we have to start early expression and restricting the use of formulas. Many times I see the baby is delivered and the formula tin also comes with the baby. That should not be happening, because that discourages the mother, that gives a feedback to the mother that my milk is not enough. That's the reason doctor is suggesting some formula feeds. So lactation counselings are very important from the time of birth of the baby. Within 1 hour, we call it golden hour, so that we can initiate the feeding, and we should do antenatal counseling. That is very important, so that the mother is aware of what to expect after the birth of the baby. Then doing kangaroo mother care, there is no any doubt about that. Non-nutritive sucking for all these babies who are less than like 30 to 34 weeks. We can start with NNS and then progress it further. And maternal adequate rest and diet is very vital to maintain the production of milk. And in case if you don't have all these things as per your requirement, you should have a human bag in the background. So this is another very helpful study where regular expression of milk by hand expression or a pump expression, what is helpful. So mothers who are using a pump on a regular basis, like 6 to 8 times in a day, they could maintain a regular expression of the milk and a good quantity of milk. You can see by day 6 it was 350 ml, by day 14 it was almost like 750 ml of milk mothers, and these are all about the preterm babies. So that is how it is important to start early expression as well as a regular expression of milk using the breast pump. So do you think all this thing is practically possible for all of you? Isn't it? It is not a difficult task to do oral application of colostrum as well as regular expression and breast pump utilization. So feed intolerance. I'm sure all of you are having intolerance about so many things. So I told you about this 26-weeker. So by day 6, baby was extubated and was on CPAP. No need to have abdominal distension and some aspirates. So what will be your next step? What will you be doing? I hope all of you are awake. You want to continue feeds or you want to hold feeds? Difficult. So this was the X-ray again. Add in the mixture. The significant distinction that we can notice. You stop feeds. I could hear some people saying like stop feeds. So there is intolerance. That is what I will say for all of you. So what is feed intolerance? That is very important. How many of you are doing regular RT aspirates? Let me put it other way around. How many of you are doing regular RT aspirates for babies? Can you raise your hands? No one is doing RT aspirates. So anyone doing RT aspirates routinely for these babies? Don't feel shy. Here we are just to interact. So doing regular RT aspirates should be banned, or should be stopped. So until and unless there is significant increments in the girth, then only you think of doing RT aspirates. And RT aspirates which are significant in the volume or significantly altered color, not like a light yellow color, it should be dark green in color. These are the significant RT aspirates. Visible loops is again a very subjective area. Babies who are on CPAP, so this baby has got a CPAP belly, and that is the reason there was some intolerance which stopped by itself if you keep the OGT open to the air. However, subsequently by day 26 of life, babies further develop these episodes of distension of abdomen, but this time you need to have a clinical picture. There are episodes of desaturation, temperature instabilities, metabolic acidosis, and this is how the X-ray was showing typically right iliac fossa, so bubble-like appearance. So this is a necrotizing enterolitis. So we should be tolerant for feed intolerance, and that is what Lord has said in second chapter again. Matra sparshas tu konteya shitoshna sukha dukkada agama paino anitya tam titikshasva bharata. So we should learn to be tolerant to whether it is a hot or cold or whatever the different changes that we face in our day-to-day life. So how fast to increase the feeds is another major thing. many people follow this weight criteria less than 1 kg, they increase by 15 ml, more than 1.1 to 1.5, 20 ml and 30 ml. So this is a very nice study, SWIFT study, where they try to do feeds of increments like directly 30 ml per kg per day, and that has showed there is no any evidence of feed intolerance or increased risk of NEC. Instead, these babies started tolerating feeds faster, they were early discharges, and there was less risk of sepsis because your gut is maintaining very well instead of exposure to just antibiotics and nil by mouth. So 30 ml per kg, that can be started. In fact, this in Indian study also, Dr. Sushma Nangia, she started full feeds for babies who are like 1 to 1.5 kg without starting parenteral nutrition. These baby also showed that there is a good tolerance of the full feeds rather than graded feeds of 30 ml per kg per day, provided the baby is hemodynamically stable. So, can we prevent extra uterine growth retardation? That is another challenge many of us face. So, what can be done? So, first and foremost, as I said, increments of the feed, kangaroo mother care, fortification of the feeds. How many of you fortifiers? Can you raise your hands? How many of you are using fortifier? There is something called as human milk fortifier, and there is even the mother's milk. They are trying to make it powder form, and they are, mother's milk fortifier also there. So when to start fortification is very important. Even we are on a small volume like 50 to 80 ml per kg, then also you can think of starting fortification for babies who are less than 1 kg. That is very important because mother's milk is only not enough for maintaining your protein requirement. That is very important to understand. And second part, the fortifier does contain additional calcium, phosphorus as well as some iron. So we need to be very diligent to start early fortification for the babies. And second part we should be careful is not to give supplements when we are giving fortification, otherwise you will lead to hypercalcemias in these babies. So micronutrient supplementation, most of us are following that, iron supplementation, but I will make a mark of that, like we should do a serum ferritin levels, and based on level of serum ferritin levels, we need to think of increasing the dose or stopping the iron supplementation. That is very important. Vitamin D, calcium, everyone is doing the supplements of that. So adequacy of feeding is another thing which many of us miss. That growth chart, growth is taken, the weight is taken most of the times, but putting in on the growth chart in the NICU as well as post discharge is very important. We expect at least like 15 gram per kg per day weight for initial 2.5 kg, and then after that we should get a catch up of the growth. That is very important for all these preterm babies. So this is also very nice verse where it's saying like Chanchal hi mana Krishna Pramati balvat dridam Tashaham nigraham manne vayureva sudushkaram, where Arjuna is saying, Krishna, my mind is so flickering, I can control wind with the help of my powers, but I can't control the mind. And in answer to that, Krishna is saying, no doubt, so no doubt what we have to do is we need to do abhyasena tu kaunteya. You have to do some efforts. So that is what all of you are listening here, but I am sure most of you are on the phones. So challenge 8, long-term goal. What we want is a balanced nutrition, not too much or too little, otherwise this will be the situation that we will be facing. So all these preterm babies, we need to calculate regular calories, regular protein intake. Don't give too much of fat, particularly many people add MCT just for the sake of weight gain. That is not good because there is a long-term problem of obesity, high blood pressure, insulin resistance, IgM concentration being on a higher side, and then cardiovascular morbidities and mortalities. So this balance is very important in all these babies. So going ahead, follow-up in this NICU graduates. So how many of your babies turn back for follow-up? How many percentage? 50%, 60%, 70%? So attrition on follow-up is a major challenge in NICU graduates. That is very important. So we need to counsel the parents. We need to tell them what is the importance of the follow-up and what do you do to improve the follow-up. We do call back to the parents. We communicate them on a regular basis. We do give some nearby references so that in case of urgencies, they can get in touch with the nearby pediatricians. That is how we try to work it out. So who needs follow-up? Not just the preterm babies having meningitis, sepsis, HIE, intraventricular hemorrhages, or inborn metabolism, symptomatic metabolic problems like hypoglycemias, hypocalcemias, and even jaundice more than 20. All these babies require a follow-up in the NICU, post-discharge follow-up. So when to do follow-up? I'm sure third day is the commonest. We want to make sure that babies and mother are getting accustomed in the home surrounding. And then subsequently 2 weeks. The vaccination time frame is a very good time frame where we get indirect follow-up by the baby for the baby, 6 weeks, 10 weeks and 14 weeks. And based on that time frame, we can decide the further follow-up. Again, the 6-month vaccination, all that things will be in line, but a fixed protocol for follow-up, a fixed protocol for free increments helps a lot for everyone to have a regular improvement in your practices or in your systems. That is very important. So should have some protocols for follow-up. So this is what I will be looking, the ABCDs of follow-up. A is your anthropometry. That is not just measurement of the weight, but along with that we need to measure the head growth as well as the length of the baby. Making sure breastfeeding. So dropping weight post-discharge, that means there is some challenge to the feeding. Either the mother is not doing adequate KMC, either the mother is not expressing milk properly, or fortification is not happening very well, or temperature instability is another major challenge that we face in these babies once they go home. So second is counseling and education. We need to counsel the parents that how important it is during after the discharge of the baby to do a regular follow-up, maintaining the adequate nutrition, so that they get the confidence. Once the baby gains weight, the parents get confidence that they are doing things rightly. So developmental assessment, there are different scales are there, which I may not be going into details. And then follow-up investigations, particularly osteopenia prematurity. Some babies require ultrasound. And then ROP screening is very important. That is also part of the further follow-ups. And then growth chart, as I said, not just the measurement, but we need to make a habit of putting it on the growth charts. Hearing is not just OE. Many people think that OE is done, so hearing is normal. It is not that. You can miss good number of sensory neural deafness in spite of doing OE. So we have to do BERA scan. That is one thing. Second thing, I just need to mention here that we used to do a regular amikacin levels or vancomycin levels, because these are all ototoxic medications. But in Indian scenario, it is not very practically possible. So any baby who has received antibiotics, amikacin or vancomycin, we should look for hearing screen. Otherwise, later they come with deafness and then subsequent problem related to speech. So immunization, again, everyone follows the immunization schedule, so I don't have to go into details. I just want to make one more point here, that we can do some preventive prophylactic medications to prevent certain viral infections like RSV infection. Palizumab, many of you must have heard about it. So that helps to decrease the chances of RSV infection for these extremely preterm babies who are at risk of development of RSV pneumonias. So this is our follow-up chart. So high-risk newborns, we have decided who are the high-risk newborns. Then we are planning discharge. Before discharge, we make sure everything is done. In the eyes, just don't look at the ROP. ROP is everyone is aware of, but many times people don't look in the eyes to look at the red reflux, which may be missing component, and then they present later with a cataract and visual problems. Then detailed neurological examination, followed by neurological evaluation, ultrasound, ROP screening for common condition like hypothyroidism, G6PD deficiencies, and congenital adrenal hyperplasia is very important in this situation. And then we need to convince them about importance of the follow-up in the clinics. And then on subsequent follow-ups, we need to look at the medical component and the developmental assessment component. And these two domains will help us to make sure that postnatally also babies not only growing well physically, but growing well mentally also. So I just remember the talk by Dalwai sir, and then I remember this verse which says like, Yadyada acharati shrestha tadadada eve tarojana sayat pramanam kurute lokas tada anuvartate. So for a child, you whatever you say them, you don't use mobile, don't use screen, but if you yourself are sitting on the screen with your hands and eyes busy on the screen, it is not going to impact. So this is how we should to apply in your practices. So take home challenges. Can I get EBM early? Can we do something to get EBM early? So early expression of milk. And we can do regular expression to maintain its supply. We need to do increments of 30 ml per kg per day and not like 0.5 ml or 1 ml per kg per day. And then moving from intolerance to tolerance, that is very important for us to understand. And we need to improve our high risk follow-up, doing a regular counseling to the parents. So before I close, this conference that we are arranging at Mumbai is a ABC conference in collaboration with the Boston Children's Hospital. We are arranging this conference. So I would invite all of you to join the session, join the conference with us. Thank you. I thought my session was just before tea, but it has been postponed. So I thought we'll do some chat.
Thank you.
If any inputs, please. Yeah.
Thank you for finishing in time after giving us Gita advice as well as neonatology.
I do try to stick to the time. That is very important for you.
Very important to finish in time. You have finished in time. You have covered mainly early TPN, early trophic feeding, early application of colostrum, early aggressive enteral feeding. You dealt with the feed intolerance. And you gave an important message not to have RT aspirations for judging feed intolerance. and human milk fortifiers we talked about, and you combine. It is most important to have a proper feeding in NSU. It shortens the duration of the NSU stay, thereby reducing the cost of the NSU stay. Most of the time they feed intolerance and they pull on the NSU stay by weeks together and increase the cost, which is very sensitive factor in Indian scenario. You want to comment?
Really a very thoughtful lecture by Dr. Jamadar sir, and he has poured out his experience of working in various top class institutes and hospitals, and I really like the presentation about enteral feeding. The thing you talked about, like early starting of the human milk or donor milk reduces the incidence of sepsis as compared to the formula feeding by 77%. That was a really important thing. Then other thing was early expression of the mother's milk within 6 hours increases the milk output in the mother. We many a times face this problem in NICU in the mothers of the preterm babies, that usually they lack the milk output during initial periods, and later on also when the baby is about to be discharged, then there is a big problem of feeding by the mother and handling at home. Thank you, sir.
Thank you for appreciating this.
Are you using probiotics routinely? Probiotics? Some of the NICs are using probiotics.
So that's very good. There is a lot of controversy about use of probiotic. If you work in Australian, NICs, there is a lot of probiotic. If you go to US and UK, there is no probiotic. So it is like, what is your experience? What we do use probiotics in a situation where we don't have, mother's milk, because mother milk does have some natural probiotic content. We do use probiotics like a Darolec that contains multiple things, not just one component of the probiotic. Yeah.
Thank you, sir. Thank you, sir. I request Dr. Purushottam Rathi sir and Dr. Sonali Rathi ma'am to kindly felicitate the dignitaries at the dignitary dais. The complexities of lower respiratory tract infection in children is just a stark reminder. Their fragile lungs demand not just solutions, but a fierce commitment to overcome the toughest challenges in pediatric care. Now we move forward towards a highly anticipated panel discussion, which is dedicated to our respected senior-most stalwart pediatrician and our guiding mentor, Dr. B.K. Kabre sir, focusing on the clinical topic of difficult and atypical lower respiratory tract infections in children. For this lecture, I would like to invite Dr. Pramod Kulkarni sir as a moderator. He is a consultant pediatrician in infectious diseases, who is joined to Smile Clinic KEM Hospital, Pune. And the panelists for this session would be Dr. Sanjay Pakmode sir, the president of Maharashtra IIP, currently working at Saili Children Hospital, Nagpur. Dr. Ram Gopal Shejra, director, Nipun Multi-Speciality Hospital, Thane, president Maha IIP 2024. Dr. Nivedita Patil ma'am, currently working as HOD and Professor, D.Y. Patil Hospital and Research Institute, Kolhapur. And Dr. Jitendra Gawane sir, currently working as consultant pediatrician, MGM Hospital, Nasik, Vashi. And Dr. Jagdish Dekne sir,
हॅलो फ्रेंड्स, धुळे IIP आणि खानदेश IIP आणि महा IIP यांचे मनपूर्वक धन्यवाद. आणि ऑल माय स्टालवर्ट पॅनलिस्ट हिअर, few of them we are missing because of some compelling reasons, and we'll be going ahead through the topics now. So difficult and atypical LRTI in children. So we are going to look at LRTI, the common ones, and few clinical real-life cases of atypical LRTI when the standard clinical manifestations were not present and how the diagnosis fooled us or turned out to be something different. So change is the only constant thing. Post-COVID, there are lot many things happening in respiratory infections in children. We all have witnessed this. There is increased awareness, diagnosis, and especially with the use of PCR in the COVID pandemic. Now it is being used frequently even at the peripheries, and we are getting now various bugs, especially viruses. Then due to COVID, initially there was drop in the respiratory tract infection burden, but as the restrictions were eased out, we have got all the vaccine preventable as well as common LRTI coming up with vengeance. Especially the measles, TB, adenovirus, last year mycoplasma, we heard of HMPV, and RSV and pertussis are already there. Co-infections have been diagnosed more and more, especially virus plus bacteria and multiple viruses as well. There is a shift in disease pattern, the seasonality has changed, RSV is now seen around the year. There is increased AMR, we all know, we have seen prescriptions of 20 contents in pandemic, especially by the physicians, and it has led to increased AMR. And universal vaccination, which was lagged during that time, again contributed to it. As well as we have PCV and HIP coverage significant there, so taking them down or differently in the common occurrence of LRTI. So LRTI, what are LRTI? So going from upper airway to lowermost airway, tracheitis, bronchitis, viral wheeze is the common clinical syndrome, then bronchiolitis, and going down to pneumonia, and little beyond that, going to the pleura as well, sometimes to the mediastinum and the other contents of the chest. What are the common etiologies? As you know, most of the clinical LRTIs which we see are bronchiolitis and bronchitis. Very few turn out to be pneumonia, and the etiology mostly nowadays are the viruses, sometimes bacteria, and the mixed content are going now in the etiology. As we know, so again the etiology below 2 months we know they are the gram negatives. Then 2 months to 5 years the commonest one. We know the trio, standard streptococcus pneumoniae, HIP, which is now replaced by others, especially NTHI and mycoplasma at older age. And above 5 years, we see the mycoplasma coming up with strep pneumoniae remaining the commonest or the only target throughout the ages. And this is the common clinical differentiation of common LRTI with simple points, and you have to fix your LRTI, suspected LRTI case in the clinical syndrome of either tracheitis, mostly it is laryngotracheobronchitis, can be bronchitis alone, bronchiolitis most common, sometimes pneumonia, and more common than that, virus-induced wheeze. With the simple clinical pointers in OPD, in a minute you can label your LRTI and manage accordingly. This is very important. So, what is LRTI? Infective inflammation of respiratory tract below the vocal cords. We have to take into account the epidemiology, which is changing, the host, that is the child's age, immunity, vaccines, and some other risk factor. We know premature babies as well as obesity is a significant risk factor for all LRTI. We know the symptoms, the basic defined LRTI, wet, cough, plus fever, and maybe with fast or difficult breathing, maybe with additional respiratory sounds or chest pain, which are occasionally present. So you have to have a wet cough plus fever to label a clinical possibility of LRTI. Signs, tachypnea, retractions may be there, respiratory sound changes, audible as well as auscultation are usually there. Lab, usually CBC, CRP suffice. Occasionally we have to go to other ones. And imaging, chest X-ray is a standard. Now ultrasound is coming up as the modality of choice for even diagnosis of pneumonia. It is said to be more sensitive than X-ray in diagnosing pneumonia. And we have to look at the course, we have to know the natural history of this common LRTI and the standard treatment of it. Atypical and difficult LRTI. Atypical is a very vague word, usually denotes the atypical organisms causing the pneumonia. and like Mycoplasma, Legionella and Chlamydia. And the difficult one, difficult to diagnose. Why there can be difficulty in diagnosing pneumonia or LRTI? The etiology can be different, clinical features can be different. Then a clinician not very competent with the clinical reading of the scenario and diagnosis and diagnostic facility. Yes, the viral LRTI are not appropriately or rather optimally diagnosed in periphery for lack of resources. Difficult to treat is not responding LRTI. So now we are going to focusing on the non-responding or difficult LRTI. How to approach difficult or non-responding LRTI? Number one, whether the diagnosis is incorrect. Review the clinical diagnosis, lab as well as imaging. Then compliance. Have you given appropriate antibiotic through appropriate food for appropriate time? Then course of the disease differs with the LRTI. We know pertussis can last for 3 months also, as well as bronchiolitis symptoms can last up to 2 to 3 weeks also. Then you have to look at, sometimes the course can be different, like recurrent or persistent. That's a different topic by itself. Complication is a commonest thing which we have to entertain when a LRTI is not responding. Then you have to look at some of the risk factors, and rarely resistant bugs also can cause LRTI. And very rarely in a child who is having recurrent LRTI, we have to think of immunological issues as well. So let us start with the case. So panelists, you have got your first case. This is Shivansh, 2 years and 5 months, weighing about 11 kg, taken UIP vaccines, brought on 20th of March to me, fever 1 day, cold, not to me, not to the referring pediatrician, 1 day fever, cold, wet cough, better with medicine. 24th, after 4 days, again got fever, we stayed there for 3 days, got better with now antibiotics as well as fluid. Then on 29th, the fever recurred again. Interfebrile throughout this course, the child was normal, playful and eating as usual. There was no complaint for the family about the playfulness or the eating of the child. On 31st, as the things were prolonged, the child was investigated and X-ray chest, I show it, it was non-contributory. The child was put on intramuscular ceftriaxone, which is a standard practice in Pune, OD, 2 days. Then it didn't help. 2nd of April, the child was admitted for the concerns of the family. Now the fever was little better, 10 to 12 hourly, but the child started getting rigors. Now the child was put on IV ceftriaxone and oral azithromycin was added, a standard practice. On 5th, the child was referred to me, for the family was very nagging, pestering and irritating. He is a very senior clinician from Pune. He referred, this is the common cause or common indication for reference to Dr. Pramod Kulkarni. वेळ देतात आणि डोक्याला तक नको. हे commonest indications आहे. The child was referred to me and with additional history, there was recurrent cold, cough, fever lasting for 3 to 5 days, every 2 weeks over last 3 months. There was history of hospitalization for dengue at 8 months of age. Brother has prolonged cough recently and grandfather has intermittent wet cough. No diagnosed TB contact, a standard history. History of eating outside food was there recently, a week ago. This was the X-ray. Can you make out anything on the X-ray? Any abnormality? Prima facie. Don't go by the session's name. Look at the X-ray and tell me. It's non-contributory. Okay? Now the child, investigations were read. The child was admitted there. HB was 11.7. Counts were borderline raised, 13,200 with 80% neutrophils. Platelets normal. CRP was 115. Urine normal. Vidal was done, which was negative. Blood culture was sent. 48 hours reports were no growth. Now, my panelists, your questions, your provisional diagnosis, and what are we dealing with, and what to do next. Dekne sir? All of you please contribute in the first 2 cases. Hello. One by one.
Am I audible? Yeah. See, now this child is obviously ill for the last 15 days. It started with a viral infection, which was started on fluid, then came co-amoxiclav. See, what is important is you have to check the compliance with co-amoxiclav. Then because probably the child did not respond, he was put on ceftriaxone because With ceftriaxone, the compliance is definitely better, maybe we ourselves give the injection. In fact, with that also the child did not get all right, and the parents, nowadays parents drive the treatment more than the pediatrician. So the patients were quite upset with no response and continued fever, which means there is some complication of viral respiratory infection, secondary bacterial infection, not responding to coamoxiclav because of the poor compliance, or the patient has an organism which is not sensitive to coamoxiclav. When the patient was started on ceftriaxone, the patient did respond but was not completely okay. The X-ray was done, apparently it did show some exudates on the right side. I think it's not an entirely normal X-ray, but which means that child requires to be investigated further. And it's important for us to know why the child is not responding, because the child is already on Fluvir, was given coamoxiclav, was given ceftriaxone, now it is given IV and also given azithromycin. So we are privileged dealing with a patient who has got a pneumonia. Now see, the first X-ray can be normal.
Sir,
the child
is it PO?
Why is it PO?
Why pneumonia?
No, but see, he started with cough, no? Yes, but
there was little cough, sir, which was getting better.
No, but see,
the cold was there for 4 days,
classical,
which went down. Very little cough. Cough was not the major complaint at all.
That is what
fever was the problem.
When it is, see, I told you, I think when fever is the main complaint, it is the parenchymal disease. And very often in parenchymal consolidations, you will hardly get any cough, but fever will be the presenting patients.
With the outside food, with little large liver on palpation, fever without focus, frankly without clinical focus. Little cold cough was there. What is your input? Anything else you want to add? What are the probabilities? What is your provisional diagnosis?
Sir, what I think is how the case began. Before the picture evolved into a complete disease, he was put on directly 2 antibiotics, which that is not the correct way to do it. Sometimes we need the disease to give some time. If the patient is afebrile in between, he is not sick, we can wait for 2 to 3 days. If the child starts with fever, cough and cold, and 2 family members are suffering, it could be viral, even if the parents are anxious.
This is more than 10 days now, ma'am.
Yeah, now the picture is different. So he was already put on those antibiotics, and I think still we have not come across what are the chest signs. We have never seen what are the respiratory findings. I don't see any systemic examination.
With the history, we'll come to physical findings next slide. So, what is your provisional diagnosis with this history and the available investigation reports?
So this is pneumonia, lower respiratory tract infection, I can say. Unless you tell me the findings, how can I say whether it is lower respiratory tract infection? I need to know what are the auscultatory findings.
Let's come to it. The child clinically had no findings at all, liver 3 centimeters, and no other clinical finding. The child was very playful. Respiratory rate was 36 per minute. Pulse was normal, CRT was normal. Auscultation, I always spend 5 minutes on chest auscultation, which I did in this case. There was no contributory finding. Breath sounds were normal, no adventitious sound, no respiratory rate changes, or no retractions at all. Clear chest. Little nasal congestion was there. Throat was normal, ear were normal. And liver was 3.5 centimeter. The child was crying, maybe little tender. So, where are we? I put it as probable enteric fever. 10 days, the child is put on ceftriaxone. Only 5 days of 5th day of IV ceftriaxone was there, probably resolving enteric fever, which will take another 2 days and go after. So we give 5 to 7 days for enteric fever to respond by fever to ceftriaxone also. What I said, it was Saturday, I said, you go back, continue with ceftriaxone, and let us review the child on Monday. Okay? Sir, I also asked them to repeat CBC CRP X-ray chest as it was done way back. 31st the X-ray was done. 2nd the blood counts were done. 4th the blood counts were done. I said let us repeat the basics to know what is happening and to follow up the blood culture report, the final one. Sometimes you can get S-typhi coming up in the latter half of the culture period. And review after 2 days if the fever is persistent. The child was sent back, was put on artemisinin and lumefantrine, and the child vomited with that new medication. Fever was worse. Parents agitated, shouting. I was to Delhi for my visa appointment. I got a call from my co-consultant. फारच त्रास देत आहेत सर, रात्री ते रडत होतं, ताप होता, सॅच्युरेशन 92-93 झाली होती, मग काय करू. म्हटलं काय करून घेणार आहे, आपला प्लॅन होता तसा, अल्ट्रासाऊंड उद्या करून घे आणि आपण बघूयात काय येते. सो next the repeat investigation done on that day, the reports were 26,000 WBCs, 65 poly with meta and bands 2%, MP negative, CRP was 143 again, ESR was 36, LFT normal, LDH was also done for a prolonged fever to look at possibilities. So now where are we? What is it? What next?
Sir, in such cases when he is coming to you at 15 days of age, on 15th day of the illness history, it is better to review the history again. So child started with very high fever and cold, coryza, cough. So definitely it was a kind of viral URI kind of thing. So started, some oral medications were given, in between he was fine. But again he started getting fever again, and then that time lumefantrine anti-artemether was given, and he came to your hospital, and then you did correctly that we are missing some other diagnosis. You did culture again and sent for looking for enteric fever as a PU pattern, and that time X-ray was showing some streaking on the right side. So if counts at your place is 26,000 with band forms and toxic granules with a high ESR, so definitely now some bacterial thing is coming up here, so which is evolving disease. So what I think is at this point, we have to think this is a bacterial respiratory evolving disease.
Again, let me tell you, definition, clinical definition of pneumonia. I follow WHO definition. Wet cough, fever, plus either tachypnea or retraction or both. This has to be there. Without that, you cannot call it pneumonia.
Right, sir. So,
secondly, on physical examination, you have to have some focal signs. Let us say decreased air entry, crepitations, or let us say something, a dull note, something being that nothing was here with meticulous auscultation. This is not pneumonia at all by clinical presentation. Now we have repeated this, I have not shown you X-ray again. And these are the counts. What is your opinion with these counts? Repeat investigation after 7 to 8 days.
So it is an initial infection, maybe the viral, because the other persons in the family were also suffering. And now with the secondary infection, and now it, after this it starts getting localized somewhere. So right now, what we, the investigations repeated in your setup, which is showing leukocytosis, a very raised CRP, and hepatomegaly. You always talk about the hepatomegaly in all the findings. So it is something infections which may be in the lower part of the lung, and that might be leading to the hepatomegaly. So I think, yeah, we can get hepatomegaly in the enteric fever also, but with this leukocytosis and CRP, we should not think of enteric fever. So I think the later X-ray will give our further investigations may tell you better where we are going.
See, basically, the fever without focus, I have labeled in this case. So focus of any pyogenic infection has to develop within 3 to 5 days. Have you seen pneumonia coming up on 10th day anytime? Pneumonia shows up at presentation or within first 3 to 4 days. Never goes beyond a week. And the signs, you always have some signs, significant symptoms. Here it is not fulfilling that. So it's a pyogenic infection, definitely now, because the counts are rising. Now it is less likely to be typhoid fever. And here is the X-ray now, which was repeated and which showed left lower lobe opacification. Not only that, ultrasound was done, which showed minimal pleural effusion 75 ml. Now, I was happy telling them the question which was nagging all of us was, what is the diagnosis? Why the child is having fever? We got it on second day of hospitalization. Now we said it is pneumonia with pleural effusion. So what will you do in this case now?
So as correctly you have done a sonography, you will see whether the fluid is tappable, because that is the only access directly to the
75
organism.
ml, are you going to tap it?
Yeah, so ultrasound guided tapping is possible in this case. And
is it mandatory if it's 75 ml?
No, the diagnostic tap we are saying, sir. Yes.
Okay, that is one thing which can be done. Is it mandatory in this case?
Rather than going for tapping, I'll go for the further investigations like CT chest. which may give a much more information about the consolidation as well as the effusion, as well as the status, other things will be more important in diagnosing or evaluating the case.
I think we are waiting for the final blood culture report.
That came sterile by that time. The outside blood culture was sterile. Now what we have got, let me tell you, this is a small pneumonia. Look at the size of the pneumonia. It is less than 25% of the left hemithorax. The pleural effusion is 75. Well, it doesn't deserve the label of complicated pneumonia also. It is simple pneumonia. Simple pneumonia not responding to ceftriaxone, that is the problem. The child has received 2 days of IM and 4 days of IV ceftriaxone. It is supposed to respond. If this small pneumonia is the problem.
So this is, if it is non-responding pneumonia, means it is not responding to our routine line of management. In 48 to 72 hours, we should think of a typical organism. So that comes with mycoplasma.
The child is on azithromycin for 5 days.
It may be resistant to erythromycin. So if you are talking of difficult pneumonia,
what I think we should remember is, the diseases do not read textbooks. 1 + 1 is never equal to 2. When you find that the patient is started with a viral respiratory infection, the family members are affected. At that time, we have a lot of viral infections in the community. In spite of ceftriaxone, the patient has not improved. Now remember, it is a bacteremic infection with a possibility of the focus being in the respiratory system. Enteric fever is unlikely. The inflammatory markers are showing a rise. They are showing ESR, then CRP, then counts, everything is rising. So it's bacteremia, which is not, I would definitely step up the antibiotics.
So what will you do?
I will swallow my pride and give
Let us
vancomycin.
be little
See,
bit, sir.
doing CT, doing MRIs, and see, patient na काय लागतं? Patient investigation do not treat the child. Investigation help you in taking decisions. So please remember, focus your attention on treatment rather than investigation. And ultrasound can tell you. I don't think I would do a CT in this patient.
It is done, everything is sufficient.
Sir, but
suppose this child is with you, what next?
Yes,
I would have given vancomycin.
Yes.
Before starting or stepping up the antibiotic, I would have definitely take a fresh set of culture from the directly fluid and send for a...
How useful it is,
yes,
if
sir.
you recollect.
So community acquired MRSA is also coming
How
up.
many? The pleural fluid yield for organisms is very, very poor. It usually is sterile. It doesn't
I don't need need tapping and all things. It's a simple left lobe consolidation with a syn pneumonic effusion. And I'll treat directly.
How will it work? So let us start with vancomycin. So antibiotic, yes, aspiration, drainage, a possibility. CTA not needed in this case of pneumonia. So added vancomycin IV, parents were counseled. Plan SOS repeat USG. The next day, we started on vancomycin, fever abated. The child was afebrile. Again with this breathlessness and hypoxia, pediatric surgeon was called in for opinion. Infusion है क्या करना है? उसने देख के क्या कर दिया? सीधा बोल दिया कल ICD डाल देंगे. That is the standard practice at KEM, let me tell you. And the child was taken for ICD insertion next day. Thin serous fluid drained only one time. No further drain over next 48 hours. ICD removed third day. Stents negative, culture no growth, TT negative. On 10th, counts were lower, CRP was lower, blood culture there was no growth. Child was discharged day 7 on oral linezolid. Day 7 of hospitalization. The child was afebrile, respiratory rate normal, no retraction, saturations normal, and no auscultatory findings even at discharge also. This is the total story, and this is the X-ray at discharge. So, what is it? Final diagnosis, simple gap with syn pneumonic effusion. Is it not atypical or difficult? Definitely both. So why did it behave like that? What is your explanation for this? The child could not be diagnosed having pneumonia because of lack of or minimal clinical symptoms and signs. Why does it happen? When does it happen? It actually happened. When does it happen? And the causes are the standard one: age, Children younger than 2 years, the standard recommendation, fever with leukocytosis more than 20,000, do a X-ray even in absence of respiratory symptoms and signs. And the cause of PO can be, or other fever without focus, can be a bacterial pneumonia. This case itself highlights it. Okay, and early or mild infection, you may not have the clinical pathological things may not have developed, the symptoms are not there. Younger age, we have said, atypical bacteria do not have standard clinical findings. Lung involvement, if it is small, as in this case, it may not show up on auscultation. Host factors rarely, and disease stage, at what stage it is. And in this particular case, it was the age of child, and early antibiotics administered to this child, which were effective antibiotics, which actually suppress the pathological development of pneumonia. So this is how we come with. Now let us come to case 2. 9-year-old boy in December 24 was referred to me from Chopra to my surgeon friend for splenectomy. He had persistent high fever, cough for 13 days, no response to oral medication. Left lumbar pain, vomiting non-bilious intermittent, very black stools 1. Hospitalized and treated locally with IV ceftriaxone, oral AZI, no relief. This was November 24, December 24. Locally done CT scan revealed multiple lesions in spleen, very abscesses. That's why the child was sent to Pune for splenectomy. There was history of abdominal trauma with impact on abdomen by bicycle handle last month. Without much symptom, the child had little pain, which resolved in few days. No family history of pulmonary TB. He was village resident, contact with livestock was there. With splenic lesions, I have given this history. So, the child was febrile and toxic, tachycardia, tachypneic retractions were there, CRT was normal, saturations were borderline, reduced movement and rib crowding on left lower zone, decreased air entry, bronchial breathing, few crepitations on left lower chest area, abdomen was soft, liver was 2 cm, spleen was not palpable, no tenderness guarding on abdomen, left lower lobe homogeneous opacity and rib crowding on chest X-ray. His investigation done at our place, counts were higher with neutrophilic predominance. CRP was 40, rest of the investigations were normal. Repeat CT scan and chest was done at Pune. CT chest with abdomen. It showed mild splenomegaly with hypo-enhancing hypodensities, 3 or 4, suggestive of splenic contusion. There was complete atelectasis of the left lower lobe of lung, and few small sub-centimetric size, mildly enlarged, homogeneously enhancing lymph node throughout the chest. What is the provisional diagnosis? Panelists, please.
Why is this patient being operated for splenectomy? Why is there splenectomy?
Multiple splenic lesions. So, splenectomy was the thought intervention by the referring surgeon or referring physician.
Okay. And then, you know, the patient has presented to with high fever, and definitely there is a, you know, a bacteremic infection in the lung on the left side, because you have, you know, focus, then you also have bilateral clinical signs, you also have a rise in neutrophils and CRP, so it's definitely an acute parenchymal infection in the lungs in a child who is about 9 years of age, and he definitely requires to be treated as a community acquired pneumonia. I would definitely give this patient azithromycin and ceftriaxone to begin
Sir,
with.
the child has received ceftriaxone, azithromycin previously.
Yes, but in what doses?
It is 13 days history.
Yes.
Appropriate dose, managed by a pediatrician.
Okay. Now,
what investigations you will think of, and what antibiotic you will start this child on?
ceftriaxone, azithromycin has been given now, and in this child actually staphylococcal infection is not very common. But I would also start this patient on vancomycin.
So you will start vancomycin?
Yes,
Yes. Anything more?
Yes, sir. So again,
Any other investigation would you like to do at this stage?
So nasopharyngeal swab also we can think of, because now prolonged history and localization is there and we are not finding the organism.
Agree.
So even if macrolides are given, azithromycin is given, we have a resistance to azithromycin also.
That was the typical story in November, December last year.
Correct.
Yes. So with that in mind, blood culture was said, which is very important in all bacterial pneumonia. Previously it was said the yield is less than 10%, don't say blood culture, but these days the tendency or the recommendations are going towards sending blood culture in severe or complicated pneumonia, because there is a good chance of getting bug from the blood culture, not from the respiratory passage. It was sent and it came positive MRSA and sensitive to almost all. Nasopharyngeal swab, as said, was positive for Mycoplasma pneumoniae and rhinovirus. Mycoplasma pneumoniae IgM antibody was done, which was positive, very high, 12.5 is the cutoff. Sputum gram stain, gram positive cocci, culture, there was no growth. AB gene expert MGIT negative, TT was negative, sickling test done in this child was negative. The child was managed on vancomycin for MRSA, oral doxy was added for Mycoplasma pneumoniae with a view of very macrolide resistant. Confirmatory molecular studies are not available anywhere. They are only available in research laboratories. Supportive care was given, oxygen therapy. Clinically, the child improved within 48 hours, resolution of fever, respiratory distress, repeat blood culture after 5 days, which is mandatory in MRSA bacteremic pneumonia, which was sterile. After 12 days, the child was discharged on oral linezolid. Final diagnosis, left lower lobe collapse consolidation, bacteremic MRSA community acquired pneumonia, co-infected with Mycoplasma pneumoniae, which was probably macrolide resistant. So this can happen to a child who is having fever and cough for a long time. Let us come to case 3. Shreyansh, 5-year-old, referred to me in February, 22 kilo, wet cough 18 days, more in early morning, cold early rhinorrhea, thick yellow-green, lasted for 5 days, eye redness with mucopurulent discharge, sticky eyes for 2 days, 2 fever episodes in between 2 to 3 days, which were low to moderate, no sore throat, ear pain, chest sound, breathlessness, chest pain, appetite activity as usual, no history of choking or sudden onset cough, grandmother had a prolonged cough just a week before, no history of chronic upper airway obstruction, no history of pulmonary TB, travel, pets, personal, family allergy. So this is the, what is your opinion? What do you think with this complaint in this boy?
So the child started with cough, cold and redness of eyes. So usually we get this symptoms in adenoviral infections. Even in some influenza you can get, but it can also be common with some bacteria like Mycoplasma. But the wet cough lasting for more than 18 days with cough as a predominant symptoms, it looks like an suppurative lung disease, but this is a very short period to call it a suppurative lung disease. We need to observe the child further at how the cough progresses.
How should we proceed in this case? What will we do?
This child is having a
cough is already more than since 18 days, almost 3 weeks, and it is also that too also wet cough. So, and only the eye redness with the mucopurulent discharge. So means can wet cough and more than 18 days history can be put in the category of some bacterial bronchitis types means thing.
Same time we have to see whether the sinusitis thing is happening, and we have to see for the tenderness.
It is decreased.
And what is important is the child is non-toxic. Nowhere the child is looking very sick in spite of 18 days. And secondly, fever is there but is low and moderate. And the child is not breathless, doesn't have chest pain or retractions like that. So probably this is a wet cough which is lingering on for a longer time than what is expected. So we need to think of something in the lungs which will...
So let us go ahead. The child was febrile, wet cough was there, stable, vitalness, respiration normal, nothing on examination, ENT normal, no sinus tenderness, X-ray chest, cervical lymph nodes were there, not very significant, BCG scar was skin, mucosa was normal, chest was clear, air entry equal, breath sounds normal, no adventitious sounds at all. There was mild pectus excavatum in this child, rest was within normal limit.
What antibiotics the child has already received for 18 days?
Amoxiclav the child has received.
Sir, I have
for 5 days.
This child is a well-grown child. We have to see. Early morning, we have to always think a chronic respiratory condition like cystic fibrosis, bronchiectasis coming out, TB. Yeah, so the approach I am telling. So this child is a well-grown child and history since 18 days and no sinus tenderness. So definitely bacterial sinusitis is out. So the possibility, as sir said, we have to think of some persistent low-grade infection in the bronchus because his copious secretions are producing and wheezing is there. So in the airways only some bacterial disease.
So we come to a prolonged bacterial LRTI, and protracted bacterial bronchitis is the diagnosis. Sir, can you tell us in brief about protracted bacterial bronchitis?
It is a diagnosis of exclusion when you find that a patient has wet cough more than 15 days to 3 weeks. When you do not find any other cause for the prolonged cough, it usually occurs after viral infection. You have to rule out other causes, like persistent foreign body or immunocompromised conditions like that. But these patients do require, this is a very common pediatric problem, and the problem is we do not give the correct dose of amoxiclavulinic acid for a fairly long time. When you give for 2-3 days, 5 days, 6 days, it doesn't take care. You have to give these patients minimum 10 days, if possible 14 days, and sometimes even 3 weeks. And that is the only thing that will probably take care of this child. So this is a very common entity, and the real answer to this is to give co-amoxiclav, but in the correct doses for as long as 2 weeks to 3 weeks.
So duration of therapy is much more important in the protracted bacterial bronchitis, because we always see when we treat, we give, as sir has said, not less than 1 week therapy, but which is not sufficient in this protracted bacterial bronchitis. It should be at least 2 weeks of antibiotics.
The usual organism is strep pneumoniae and Moraxella catarrhalis are the commonest organisms in this. H. influenza less likely because of immunization now.
So with these 3 cases, we have seen some of the difficult cases of LRTI. The message is always follow a structured evaluation of prolonged or atypical LRTI in form of, is the diagnosis correct, is the treatment well compliant and appropriate, is there any complication, is there any risk factor, and lastly think of immunity. So that should be an approach towards a difficult LRTI which is not responding. Thank you very much for your inputs.
Sir, last take home is?
That is what I have said.
I request Dr. Neeta Hatkar Madam and Dr. Swati Bansal to felicitate all the dignitaries. Now we proceed towards the inauguration ceremony of this midterm summer CME. Now I request Dr. Abhinay Darwade to please take over the ceremony.
हॅलो, नमस्कार. मी डॉक्टर अभिनय दरवडे. कार्यक्रमाला पुढे जाण्याच्या आधी आपल्या रूम्स आपण जर चेकआउट केलेल्या नसतील तर त्याची आठवण मी करून देतो. आपल्या रूम्स नक्की चेकआउट करा, आणि चेकआउट करताना जर लगेज तिथे ठेवायचं असेल तर ठेवायला हरकत नाही, पण रूम्स नक्की चेकआउट करा. कुठलीही कॉन्फरन्स म्हटली की सुरुवातीला पुणे आणि मुंबई एवढंच नाव यायचं, पण असं पण असतं की पेरिफेरीमध्ये सुद्धा काही गावं असतात, आणि त्या गावांना सुद्धा महानगरांच्या पलीकडे जाऊन परिषदा आयोजित झाल्या पाहिजे अशा स्वरूपाचा एक विचार आणि छोट्या शहरांना प्रतिनिधित्व देण्याचा एक सन्माननीय विचार पुढे आला. आणि आज धुळ्याला पहिली खानदेशकॉन परिषद संयोजन करताना आम्हाला अत्यंतिक आनंद होतोय. या परिषदेचं औपचारिक उद्घाटन आता होणार आहे. मी आजच्या मान्यवरांना एक एक करून मंचावर आमंत्रित करतो. आय रिक्वेस्ट डॉक्टर संजय जोशी सर टू प्लीज एस्कॉट आवर बिलव्ड नॅशनल ट्रेजरर ऑफ सेंट्रल IIP डॉक्टर अतानु भद्रा सर. टाळ्या वाजवा. याच्यानंतर जेवायला जायचं आहे आपल्याला. यानंतर दादाभाई आपण आदरणीय डॉक्टर ममता पाटील मॅडमना मंचावर पाचारण करावं.
डॉक्टर तुषार कानडे यांना मी विनंती करतो की महाराष्ट्र राज्य IAPचे आमचे लाडके अध्यक्ष डॉक्टर संजय पाखमोडे सरांना मंचावर त्यांनी आमंत्रित करावं. त्यानंतर डॉक्टर अविनाश, तुम्ही जॉईंट नॅशनल कन्व्हेनर आमचे लाडके महाराष्ट्र राज्याचे सचिव सेंट्रल EB डॉक्टर अमोल पवार सरांना मंचावर आमंत्रित करूया. अत्यंत मधुर गळ्याचे डॉक्टर रवींद्र सोनवणे सरांना सुद्धा दादाभाई आपण मंचावर आमंत्रित करूया. टाळ्या खरं म्हणजे वाजत राहायला पाहिजे. तसंच या खानदेशकॉनचे ऑर्गनायझिंग चेअरमन डॉक्टर संजय जोशी सर, ऑर्गनायझिंग सेक्रेटरी डॉक्टर महेश अहिरराव सर, धुळे IAPचे अध्यक्ष डॉक्टर हसतमुख असे डॉक्टर तुषार कानडे सर आणि सचिव डॉक्टर दादाभाई या सगळ्यांना सुद्धा मी मंचावर आसनस्थ होण्यासाठी विनंती करतो. या परिषदेची सुरुवात आता खरं म्हणजे होतीये. सगळे मान्यवर इथे विराजमान झालेले आहेत. कुठल्याही कार्यक्रमाची सुरुवात ही खरं म्हणजे दीपप्रज्वलनानं होत असते. आपण आधी सुरुवातीला दीपप्रज्वलन करणार आहोत. या परिषदेच्या सुरुवातीला मी सर्व मान्यवरांना दीपप्रज्वलनाकरिता समयीकडे येण्याची विनंती करतो. पहिल्या खानदेशकॉनचं यावेळेला संयोजन करताना बऱ्यापैकी गमती जमती झालेल्या आहेत. रात्रंदिवस एक करून आम्ही सगळेच्या सगळे या पहिल्या उत्साही कॉन्फरन्सचं आयोजन हे इथे करत होतो आणि हे करताना खऱ्या अर्थानं मजा आली. डॉक्टर संजय पाखमोडे सरांचं मंचावर आगमन होते. परत एकदा टाळ्यांच्या गजरात आपण त्यांचं स्वागत करूया आणि मी सर्व मान्यवरांना विनंती करतो की त्यांनी दीप प्रज्वलनासाठी इथे यावं. सर्व EB मेंबर्सना मी विनंती करतो की त्यांनी सुद्धा या दीप प्रज्वलनासाठी इथे यायचं. दीपा मॅडम, निवेदिता मॅडम, सर्व EB मेंबर्सना मी विनंती करतो की त्यांनी यावं. निखिल सर, काय करता काहीतरी करावं लागतं ना माझं. हा वर करा, वर करा, वर जा, वर जा, सगळे जा. नाही हरकत नाही. असं न ठरवता काही गोष्टी स्पॉन्टेनियसली झालेल्या मजा येतात आणि परिषदांमध्ये ह्याच्याच खरं मजा असते की ऐन वेळेला काही काही गोष्टी बदलत असतात. आता काल नाही का आम्ही तुमचं लग्न परत एकदा लावलं. हरकत नाही. गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमंडिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि. या गणेश वंदनेबरोबर आपण पुन्हा एकदा दीप प्रज्वलनाकडे वळतो आहोत. एक दिवा काय करू शकतो हे आपण बघतो आहोत. एक दिवा संपूर्ण घर प्रकाशित करत असतो. ज्ञानाचे असंख्य दिवे विवेकाधिष्ठित समाजाची रचना करत असतात. दीप प्रज्वलन इथे संपन्न होत आहे.
अतिशय प्रसन्न वातावरणामध्ये हे दीपप्रज्वलन संपन्न झालेलं आहे. मी सर्व मान्यवरांचे पुन्हा एकदा मनपूर्वक धन्यवाद करून त्यांना पुन्हा एकदा आसनस्थ होण्याची विनंती करतो. यानंतर आपणा सर्वांच्या सौहार्दपूर्ण स्वागतासाठी मी आपले ऑर्गनायझिंग सेक्रेटरी डॉक्टर महेश अहिरराव सरांना इथे आमंत्रित करतो.
Thank you, Abhinay. I welcome our chief guest today, National CIP Treasurer, Dr. Atanu Badra sir. Guest of honor, Secretary of Jawahar Medical Foundation, Mamta Tai Patil. Maharashtra IIP President, Dr. Sanjay Pakmode. Maharashtra IIP Secretary General, Dr. Amol Pawar. Maharashtra IIP Treasurer, Dr. Ravindra Sonavne. Organizing chairperson for this conference, Dr. Sanjay Joshi sir, Dhule IIP President, Dr. Tushar Kanade, Secretary Dr. Dadabhai Patil, all the respected OB and EB members of Maharashtra IIP, and all the delegates present today. First of all, I welcome all the delegates for this first ever Khandeshcon or first ever state level CME meet granted to Dhule. For this, I would like to express my gratitude to Maharashtra IIP President, Secretary, all the office bearers, all the EBs, all the central IIP members for granting us and trusting us to hold this CME at Dhule. Sir's motto, President Sir's motto for this year, as he said yesterday, was reaching the unreached. So for this CME, what we thought, the topics should be in a way that they should cover the last pediatrician of the city or of the society. So the topics were designed to cover all the practical aspects of practicing pediatricians. That is the P4, which is the theme of the conference. For this, I would like to congratulate our scientific committee under the leadership of Dr. Jagdish Pakhre sir. Sir, this conference would not have been possible without the involvement of all the men in grey who are roaming around, and without the efforts for the last 2 to 3 months efforts of this men in grey. I hope that everyone is enjoying the hospitality and as well as the scientific content of the conference. Lastly, we would like to shoulder, the IIP Dhule, we would like to shoulder the bigger responsibility if the state authorities and the national authorities, they will confer on us, and we would want to go on a higher stage. So if they grant us or support us for holding events like Mahapedicon, we are ready for that, sir. To conclude, organizing an event is always a big deal, and there may be some glitches, there may be some inconveniences caused to all of you. So as an organizing secretary, I in advance express my apology if there are any inconveniences to any of the delegates, and I stop here. Thank you very much.
आभारी आहे महेश सर. यानंतर या परिषदेची एकूण चित्रछटा आपल्या समोर रेखाटण्यासाठी आमचे ऑर्गनायझिंग चेअरमन डॉक्टर संजय जोशी सरांना यांना मी आमंत्रित करतो की खानदेशकॉन बद्दल त्यांनी ही चित्रछटा आमच्या समोर रेखाटावी.
Chief guest of today's function, Treasurer Central IIP, Dr. Atanu Badra sir. Guest of honor, Dr. Sanjay Pakmode sir. Our guest of honor and our old Khandeshi man, we call him Vitamin D3, a dashing, dynamic, dazzling, down-to-earth EV member, Dr. Amol Pawar. Our respected chairman of ACPM Medical College, Dr. Mamta Madam. Treasurer Dr. Ravindra Sonavne, all the EB members of Maharashtra State, or the EB members of the Central IIP, esteemed faculties, distinguished guests, and valued delegates. I extend my warm and heartfelt welcome to all of you, and we are really truly honored and deeply indebted for taking out your time from your busy schedule and participating in an August gathering at such a remote place of Maharashtra, that is Dhule. Actually, the story started 5 years back when in 2019 we were granted the same CME. But then the COVID came and it actually thrashed our dreams. So this time when the CME was given to us, we actually flew in the clouds of ecstasy. We were very happy. and for that I really thank all the Mahaiap people. In our day-to-day practice, we face a lot of problems. We have restricted sources, limited investigations, and so we thought that the theme of the conference should be P4, that is practical problems of practicing pediatricians. So that was the theme. And I know that due to the prestigious deliberation of all the speakers, we will definitely give the answers. We have a very academically rich program which includes various presentations, panel discussions, and we have got galaxy of faculties, distinguished faculties, which will deliver keynote lectures and knowledge capsules. In addition to the educational feast, the charming and lovely venue of Swarnaspasha Resort, which you must have experienced yesterday night, is waiting to serve you the various mouth-watering delicacies of Khandesh. Dhule is actually very strategically situated at the cross of two main highways, that is Mumbai-Agra highway and Surat-Nagpur highway. And our city is covered, totally surrounded by the hills of Satpura, and which inhabit lot of tribal population. And we have got two important major health issues. One, we fit into the belt of sickle cell anemia and thalassemia, so we get a lot of cases of hemolytic anemia, and secondly malnutrition. So with this conference, it will be a very great opportunity for all of us and my colleagues to get various knowledge about the things. Lastly, I would like to again express my heartfelt gratitude to Pakmode sir, Amol Pawar sir, Sonode sir, EB members. Members of my Dhule IIP are the backbones of this conference, and because of their collaborative effort, it is possible. Without their help, it was not possible to organize this thing. I will not dare to mention any specific names because it is one single family of our Dhule IIP, and every member of my family have collaborated, contributed meticulously to decorate this conference. The sponsors and all those who have contributed to this mega event needs a big applause. If there are some flaws in the arrangement, I take it as my personal short effort, and if you find anything, that is the success of our whole family. Thank you. I wish a very grand success.
देव आनंद रिटायर्ड होत असतात, राजेश खन्ना रिटायर्ड होत असतात, पण जे कधीच रिटायर्ड होत नसतात असे आमचे सदोदित चैतन्याचे माहेरघर डॉक्टर संजय जोशी सर यांच्यानंतर आपल्या गोड सुरावटीसाठी सुपरिचित असलेले महाराष्ट्र IIPचे खजिनदार डॉक्टर रवींद्र सोनवणे सरांना मी मनोगतासाठी पाचारण करतो.
सर्वात पहिले खानदेशकॉनचे 5 पांडव यांचं मी अभिनंदन करतो. डॉक्टर संजय जोशी युधिष्ठिर, त्यानंतर दादा आणि भाऊ, दादा भाऊ असे दोघं म्हणजे एकच माणूस येतो. त्यानंतर शंभूचा अवतार महेश आहिरराव, आणि त्यानंतर हुशार कानडे माझ्या डाव्या बाजूला बसलेले, कानडा राजा पंढरीचा जे काय, आणि 5वे अविनाश खजिनदार. तर हे 5 पांडवांचा आणि त्यांच्या टीमचा मी खरंच सत्कार करतो. खानदेशीकॉन म्हणजे धुळ्यामध्ये मी ऑलरेडी MBBS करून गेलेलो आहे, आणि त्यावेळेचं धुळे आणि आत्ताचं धुळे मी खरंच म्हणजे आता इथे काश्मीरमध्ये असल्यासारखं वाटते. बाहेर भले राजस्थान आहे, पण इथे मला खूपच छान वाटते. आणि ज्या पद्धतीने वॉर्म हॉस्पिटॅलिटी धुळे IIP टीमनी दाखवलेले त्याबद्दल खरंच मी ग्रॅटिट्यूड व्यक्त करतो. आणि चीफ गेस्ट म्हणजे त्यांचं बोलण्या अगोदर किशोर कुमार, अमिताभ बच्चन, सौरभ गांगुली, मिथुन चक्रवर्ती हे सगळे माझे फेवरेट आहेत, पण त्यांच्यापेक्षा पण जास्त फेवरेट आहे डॉक्टर अतुनू भद्रा सर. म्हणजे ते रसगुल्ला किंवा गुलाबजामुन सारखे बोलीने पण स्वीट्स आहे आणि मनाने पण स्वीट आहे. त्यानंतर आमचे महाआयपीचे प्रेसिडेंट बॉस म्हणजे माझे बॉस डॉक्टर संजय पाकमोले, आणि त्यांचे म्हणजे जी कोणताही मोबाईल हा बॅटरीशिवाय चालू शकत नाही, तर ती बॅटरी म्हणजे ती कधीही न संपणारी. आपला जरी मोबाईल 4-5 तासात संपून जातो, तर बॅटरी असे आमचे महाआयपीचे सेक्रेटरी डॉक्टर अमोल पवार, म्हणजे त्या बॅटरीशिवाय मोबाईल नाही चालू शकत, तर ते असे आमचे बाहुबली डॉक्टर अमोल पवार. हे दोघं महाआयपीला जसं चंद्र हा कलेकलेने वाढत जातो तशी महाआयपीची प्रगती उत्तरोत्तर वाढत जाते. जसे वेबिनार्स नवीन नवीन युवा लोकांना ते दोघं संधी देतात आहे. म्हणजे मी फक्त पैसे सांभाळण्याचं काम करतोय बिंग खजिनदार. नंतर आम्ही ममता पाटील मॅडम म्हणजे त्या ACPMचे चेअरमॅन आहे आणि आमचे मित्र जे नाशिकचे डॉक्टर योगेश पाटील त्यांचे नातेवाईक पण आहे. डॉक्टर योगेश पाटील बऱ्याच वेळा तुमचं नाव घेतात तर ते आज दर्शनी झालं. तर आणि अनेक सगळे फॅकल्टीज आणि म्हणजे सर्वात बेस्ट म्हणजे राज्यस्तरीय कॉन्फरन्स वाटते. ज्या पद्धतीने सायंटिफिक कंटेंट निवडला गेलेला आहे त्याबद्दल पण सायंटिफिक चेअरमन डॉक्टर जगदीश पाखरे सर यांचा पण सत्कार. त्यांच्या मुलीची परीक्षा काही वर्षापूर्वी ॲज अ एक्सटर्नल एक्झामिनर घेतली होती मी, ते मुद्दाहून आवर्जून सांगतो. तर आणि सर्वात महत्त्वाचं आहे की सर्व डेलिगेट्स पार्टिसिपेंट्स ते याचा गाभा असतात. म्हणजे कोणत्याही कॉन्फरन्सचा गाभा असतात. ज्या पद्धतीने सायंटिफिक याला पूर्ण हे हॉल हा भरलेला होता. जनरली कुठेही जा कॉन्फरन्समध्ये इव्हन नॅशनलला हार्डली 15-20% लोक असतात किंवा 20 ते 30%, पण इथे 80 ते 100% अटेंडन्स होता. म्हणजे इथले लोक पण सायन्सचे भुकेले आहेत. म्हणजे जेवणाचे तर सगळेच असतात पण सायन्सचे पण भुकेले हे मला दिसलं. आणि एवढं बोलून मी आवर्त घेतो, नाही तर मला हे स्टेजवरून ओढायचे. थँक्यू.
थँक्यू सर. बऱ्याच वेळ गाणं म्हणतात, म्हणजे गाणं म्हणायला लागले की बराच काळ ते स्टेजवर असतात. असाच तो कार्यक्रम आता इथे सुद्धा ते रंगवायला घेतला होता. सटाणा, नाशिक, नागपूर, पुणे, मुंबई, अगदी इतकंच नाही तर महाराष्ट्राबाहेर सुद्धा बँगलोर, हैदराबाद आणि अगदी तिथे पण नाही की त्याच्याही पलीकडे जाऊन परवा तर झूम मिटिंगला स्पेस स्टेशनवरून काहीतरी बोलत होते असे डॉक्टर अमोल पवार आता इथे आपल्याबरोबर आहेत. तर सटाणा ते स्पेस स्टेशन असं जादुई प्रवास करणारे आमचे लाडके, ज्यांच्याकडे जादुई काहीतरी असं आहे की एकाच वेळेला ते कुठेही असू शकतात, तर ते डॉक्टर अमोल पवार सर. हां, IMAचे आमचे धुळ्याचे अध्यक्ष डॉक्टर गलाणी सर सुद्धा इथे उपस्थित आहेत. त्यांचं सुद्धा टाळ्यांच्या गजरात आपण स्वागत करूया. नाही हो,
धन्यवाद अभिनय. वेळ थोडा कमी घ्यावा लागणार मला कारण आपल्याला बरेच गेस्टला ऐकायचं आहे. 2 मिनिटं. येस सर, थँक्यू. सर्वप्रथम आपले कार्यक्रमाचे अध्यक्ष डॉक्टर अट्टानू बद्रा सर, ही केम ऑल द वे फ्रॉम कलकत्ता टू धुळे. He is working very lot since last 2-3 years and he has reached to almost whatever Dr. Sanjay Pakmode sir vision is there, reached to unreached. So that thing after Dr. Basavaraja sir, one of the OB from National IIP who is doing is Dr. Attanu Badra sir. Then Dr. Mamta Patil madam, सर्व dignitaries on the dais, of the dais, सर्व माझे seniors, colleagues and friends from all over Dhule, Jalgaon district, then Malegaon taluka, then Nandurbar district, and all the faculties, all the executive board members of Central IIP, Maharashtra IIP, and all the PG students as well. This has been a really very long journey actually. 5 वर्षापूर्वी आपल्याला ही मिड टर्म CME अलॉट झालेली होती आणि ती काही कारणास्तव कोविडमुळे कॅन्सल झाली, डेट फायनल झालेली होती, सर्व गोष्टी झालेल्या होत्या आणि ती आज आपण 5 वर्षांनी का होईना आज घेतोय. संजय जोशी सरांचं एक ड्रीम होतं की ही मिड टर्म CME करावी धुळ्याने आणि ती यावर्षी सर्वांच्या संमतीने आपण ती करतोय. आज आपल्याला भरपूर म्हणजे पहिल्या लेक्चर पासून आज काही जण जेवायला गेलेले असतील, थोडा हॉल रिकामा आहे, पण पहिल्या लेक्चर पासून आपल्याला मोर दॅन 80ची अटेंडन्स लाभली आणि सर्व फॅकल्टीज आपले दूरदूरून म्हणजे मुंबईचे फॅकल्टीज आले, पुण्याहून आले, कोल्हापूर सर्व एरियामधून फॅकल्टीज आले आणि नॅशनल OB म्हणून ज्यांनी काम केले डॉक्टर समीर दलवाई, डॉक्टर गणेश कुलकर्णी सर, हे सुद्धा मंडळी, डॉक्टर जितेंद्र गावणे सर, ही सुद्धा मंडळी आपल्यात इथं प्रेझेंट आहे. म्हणजे धुळ्यासाठी, धुळ्यासारख्या छोट्या IIP ब्रँचसाठी ही खरंच भूषणावं गोष्ट आहे. उरलेले जे सायन्स आहे ते सर्वांनी जरूर ऐकावं यासाठी मी तुम्हाला परत एकदा विनंती करतो आणि पुढे काही फेलिसिटेशन्स आणि चीफ गेस्टचे भाषणं राहतील आणि त्यानंतर आपण लंचला ब्रेक घेणार. तर पुढचं एक 20 मिनिटं फक्त आम्हाला थोडं सहकार्य करा. थँक्यू.
मध्ये मध्ये सांगावं लागतं की नंतर जेवण आहे म्हणून. आपल्या महाराष्ट्र राज्य IAPचे हसतमुख अध्यक्ष ज्यांचे 2 लग्न एकाच व्यक्तीबरोबर झाले, काल एक परत एकदा लागलं, असे डॉक्टर संजय पाकमोडे सरांना मी आता मनोगतासाठी आमंत्रित करतो.
नमस्कार. सर्वप्रथम IAP धुळेचं मी मनापासून स्वागत करतोय, की अभिनंदन करतोय की त्यांनी इतकं छान म्हणजे कालचा वॅक मॉड्यूल आणि आजची CME खानदेशखान नावाने जे 2 दिवसात करून दाखवली त्याचा मला खरंच अभिमान वाटतो. आणि ज्याप्रमाणे महेश बोलला की भविष्यात आम्हाला याच्यापेक्षा मोठी जिम्मेदारी दिली तरी आम्ही ती खंबीरपणे सांभाळू आणि आम्हाला त्याच्यात काही शंकाच नाही, नो डाऊट की आज 2 दिवसात आम्ही जे बघितलं त्यात असं वाटतं की अशानंतर कोणतीही मोठी जबाबदारी ते समर्थपणे पार पाडू शकतात. सर्वप्रथम काल ज्याप्रमाणे दुसऱ्यांदा लग्न घडवून आणलं त्याबद्दल मला काल रात्री स्टेजवर बोलायचं होतं, ते राहून गेलं. म्हणून मी परत घडवून आणण्याबद्दल तुम्हा लोकांना खरंच मी तुमचा आभारी आहे. कारण माझी मुलगी मला म्हणाली की मी नशीबवान आहे की माझ्या आईबाबांचं लग्न बघतीये. अतिशय काल म्हणजे आमच्या येतानीच आमच्या मनात होतं की असं काही म्हणजे इथे होईल असं नाही. आम्ही ठरवलं होतं मी मोठ्यांसोबत जेव्हा सेलिब्रेट करणार तेव्हा असा प्रकारचं फंक्शन करणार आमच्या मुलांनी. पण काल धुळे IAPनी हे घडवून आणलं आणि ज्या प्रकारे घडवून आणलं ते अतिशय म्हणजे खूपच त्याचा मला आनंद आहे. रादर माझं मन गहिवरून आलं होतं की आय वॉज व्हेरी इमोशनल दॅट टाइम की अशा प्रकारे म्हणजे एक असं वाटायचं की दुसऱ्यांच्या बँक्वेटमध्ये उगीच वेळ काय घ्यायचा, पण थोड्याशा वेळाकरता करून त्यांनी ते घडवून आणलं. वन्स अगेन मी तुम्हा सर्वांचा आभारी आहे. आणि मंचावरची जेवढे व्यक्ती आहेत पहिले त्यांना मला ॲड्रेस करावाच लागेल. डॉक्टर अतानु सर, डॉक्टर ममता मॅडम, डॉक्टर अमोल, डॉक्टर रवींद्र सोनवणे, जोशी सर, महेश अहिरराव सर, तुषार कानडे, दादाभाई, अविनाश, हे सर्व या लोकांनी आणि धुळ्याच्या टीमनी जे 2 दिवसात त्यांच्यामधली जी आताच रवींद्र सोनवणे बोललेत की 5 पांडव आहे आणि त्यांच्यासोबत मोठी टीम आणि या टीमने एवढा मोठा कार्यक्रम अतिशय चांगल्या प्रकारे पार पडून आणला. आणि खरंच या 2 दिवसात असं वाटलं नाही आम्हाला की आम्ही कुठे अशा ठिकाणी आलो की ज्या ठिकाणी कुठे प्रॉब्लेम्स होत आहे किंवा कुठे काही हे होत आहे. सर्व गोष्टी नीट अँड मेटिक्युलसली अरेंज केल्या होत्या. सर्व गोष्टी हॉस्पिटॅलिटीबद्दल तर बोलायलाच नाही पाहिजे. म्हणजे त्यांची हॉस्पिटॅलिटी प्रत्येक ठिकाणी तो टच होता, धुळेवाला टच होता. जेवलात का, चहा घेतला का, मीन्स दॅट वॉज रिअली ऑसम. इट वॉज रिअली वंडरफुल. मग अशी महेश म्हणला की काही त्रुटी असतील तर जोशी सर पण म्हणले की तो त्रुटी असतील तर मला हे करा म्हणून. तर मला एक जस्ट पुलंचं एक हे आठवतं. त्यांनी म्हटलंय घड्याळाचं काय आणि माणसाचं काय, आतलं तोल सांभाळणारं चाक नीट राहिलं की फार पुढे जाण्याची भीती नाही आणि फार मागे पडण्याची पण नाही. अगदी आतलं चाक समजा बरोबर आहे तर अगदी सर्व काही बरोबर आहे. तुमचं आतलं चाक एकदम सॉलिड आहे. या कार्यक्रमात थ्रू मला एकच सांगावं लागतं नाही, एका सुंदर नात्यावर पुलंनी परत लिहिलं आहे, मैत्री एक सोपी व्याख्या आहे. रोज आठवणी यावी असं काही नाही, रोज भेट व्हावी असंही काही नाही. एवढंच कशाला रोज बोलणं व्हावं असंही काहीच नाही. पण मी तुला विसरणार नाही ही झाली खात्री आणि तुला याची जाणीव असणं ही झाली मैत्री. शेवटी काय हो, भेटी नाही झाल्या तरी गाठी बसणं महत्त्वाचं आहे. आणि ज्यांनीही जाणलं त्यांनी माणसातलं माणूस पण जाणलं. अशा सगळ्या माझ्या धुळे मित्रांना शुभेच्छा आणि अशीच ही नाती टिकवा आणि आयुष्याचा आनंद घ्या. धन्यवाद. जय हिंद, जय महाराष्ट्र.
धन्यवाद सर. पुलंचं सुद्धा आगमन या निमित्तानं या कार्यक्रमामध्ये साहित्यिकाच्या अर्थानं झालं ही खूप चांगली आणि गमतीची गोष्ट आहे. कारण मराठीसाठी 2 भावंड महाराष्ट्रामध्ये भांडताना दिसत आहेत आणि त्या मराठीला अभिजातता मिळाल्यानंतर ही मराठी इथे स्टेजवर परिषदांमध्ये वापरली जाणं हे अतिशय गौरवास्पद बाब आहे. याच्यानंतर जवाहर मेडिकल फाउंडेशनच्या आणि SCPM मेडिकल कॉलेजच्या सचिव आणि सर्वेसर्वा अतिशय निगर्वी आणि सुस्वभावी अशा आदरणीय डॉक्टर ममता पाटील मॅडमना मी मनोगतासाठी विनंती करतो.
सन्माननीय व्यासपीठ, उपस्थित सर्व डेलिगेट्स, धुळ्याच्या बाहेरून आलेले, पीडियाट्रिक म्हटलं ना का माझ्या एकदम माझे लहान काका सर्व ओळखत असतील, नानासाहेब, ज्यांच्याशी मी जास्त अटॅच होती वडिलांपेक्षा. ते पीडियाट्रिशियन होते, MRCP खानदेशात जवळजवळ सर्वांनाच माहिती आहे. आज पण जेव्हा मी पीडियाट्रिक वॉर्डात जाते तर पहिले त्यांची कॅबिन लागते आणि मग पीडियाट्रिक वॉर्ड सुरू होतो. जेव्हा अहिराव सर आणि जोशी सर मला म्हटले की मॅडम अशी कॉन्फरन्स ठेवतोय, तुम्हाला यायचं आहे, एकदम माझ्या डोळ्यासमोर तेव्हा नानासाहेबांचा हे आला की अरे ही कॉन्फरन्स CME अटेंड करून आपण कुठंतरी नानासाहेबांना एक आदरांजली माझ्याकडनं होईल. आज अहिराव सर म्हटले की नक्कीच जर मोठी जबाबदारी दिली तर आम्ही तयार आहोत. सर, जवाहर फॅमिली पण याबरोबर तुमच्याबरोबर तेवढ्याच हक्काने उभी राहील. कुठे पण तुम्हाला काही गरज पडली, जवाहर फॅमिली कायम जशी अण्णा नानांच्या वेळेस उभी राहायची तशीच आत्ता उभी राहील, ही आम्ही दोघं भाऊ बहिणी गॅरंटी घेतो. सरांना मी म्हटली सर खानदेश म्हटलं का थोडंसं एकदम मनाशी लागणारं असतं. खानदेशी व्यक्तींना जरा जवळच राहतं. ते इतके वर्ष नाशिकला असली का अरे नाही खानदेशी खायला जायचे, खानदेशी ते, पण आता खानदेशातच आल्यामुळे आजचा हा कार्यक्रम पीडियाट्रिक महाकॉन, सर मला सांगत होते की 80% अटेंडन्स होता, वॅक्सिनेशनवर झालं आणि खरंच गरजेचं आहे. मी अहिराव सर आणि जोशी सरांना म्हटलो की SCPM मेडिकल कॉलेजकडनं, पीडियाट्रिक डिपार्टमेंटकडनं जर आपल्याला एखादं गाव किंवा कुपोषित बालकं दत्तक घ्यायचे असतील तर नक्कीच आपण तयार आहोत. त्याच्यासाठी जर तुमची पण साथ मिळाली सर्वच पीडियाट्रिशियन्सची तर एक चांगला उपक्रम आपण सुरू करू शकतो असं मला वाटतं. आणि याच्यात SCPM मेडिकल कॉलेज पण तुमच्याबरोबर राहील. याच्यात जास्त वेळ न घेता मी तुम्हाला सर्वांना शुभेच्छा देते आणि इथेच थांबते. धन्यवाद.
धन्यवाद मॅडम. तुम्ही दिलेलं आश्वासन आमच्यासाठी अत्यंत आनंदाची गोष्ट आहे. आम्ही परत एकदा आभार मानतो. याच्यानंतर आभारापलीकडे सुद्धा एक महत्त्वाची गोष्ट असते की इतक्या लांबून लांबून तुम्ही सगळे लोक आलात. हे आमचे सोफे सगळे धन्य झाले. तुम्ही सगळे इथे बसलेला आहात. 2 दिवसाच्या परिषदेमध्ये तुम्ही सगळे आलेला आहात. आनंद होता. घेऊन जाऊ शकता, कसं काय प्रॉब्लेम. सुरुवातीला आपण या सोफ्यावरच विराजमान झालेल्या या सगळ्या मंडळींचं खरं म्हणजे सत्कार करणार आहोत. हा पाहुणचाराचा एक महत्त्वाचा सोहळा असतो. पहिलं जे नाव आहे ते डॉक्टर समीर दलवाई सर, पास्ट ट्रेजरर ऑफ सेंट्रल IIP, आणि जे कधीच वयस्कर होत नाहीत, जे सतत तरुण होत जातात उलट्या दिशेनं, ते डॉक्टर समीर दलवाई सर. सर प्लीज या मंचावर. त्यांचा सत्कार आपण ममता पाटील मॅडमच्या हस्ते करतो आहोत. याच्यानंतर डॉक्टर गणेश कुलकर्णी सर, पास्ट EB नॅशनल IIP आणि नॅशनल कोऑर्डिनेटर ऑफ द व्हॅक्सिन्स मॉड्यूल, आमचे मित्र. मी डॉक्टर अतानु भद्रा सरांना विनंती करतो की त्यांनी गणेश कुलकर्णी सरांचा सुद्धा सत्कार करावा. फोटोग्राफर आहे कुठे? आपण नंतर जेवायला जाऊयात. आता इकडे लक्ष. यानंतर डॉक्टर जितेंद्र गव्हाणे सर, पास्ट EB नॅशनल IIP आणि चीफ सायंटिफिक चेअरपर्सन ऑफ हैदराबाद पेडिकॉन, डॉक्टर जितेंद्र गव्हाणे सरांचा सत्कार डॉक्टर संजय जोशी सर करतील अशी मी त्यांना विनंती करतो. यानंतर डॉक्टर पंकज अग्रवाल सर, व्हाईस प्रेसिडेंट महाराष्ट्र IIP, यांचा सत्कार डॉक्टर सचिन पाटील आहेत का? डॉक्टर सचिन पटेल यांनी करावा अशी मी त्यांना विनंती करतो. अच्छा, दोघंही नाही आहेत. डॉक्टर संजय देशमुख सर, कन्व्हेनर महाराष्ट्र IIP, यांचा सत्कार सचिन पटेल सरांनी करावा अशी मी त्यांना विनंती करतो. डॉक्टर निवेदिता पाटील मॅडम, जॉईंट सेक्रेटरी महाराष्ट्र IIP. मी डॉक्टर नीता हटकर मॅडमला विनंती करतो की त्यांनी त्यांचा सत्कार करावा. डॉक्टर संजीव जोशी सर, कुछ ना कहो म्हणत म्हणत बरंच काही म्हणून गेलेले काल, अप्रतिम गायले सर, सेंट्रल IIPचे EB मेंबर. डॉक्टर वीरेंद्र सैंदाणे यांना मी विनंती करतो की त्यांनी त्यांचा सत्कार करावा. वीरेंद्र आहे. डॉक्टर सतीश राठी सरांना मी विनंती करतो की त्यांनी त्यांचा सत्कार करावा. राठी सर आहेत. डॉक्टर मिलिंद सनेर, डॉक्टर संजीव जोशी सरांचा सत्कार करावा. यानंतर डॉक्टर दीपा फिरके मॅडम, एक्झिक्युटिव्ह बॉडी मेंबर ऑफ सेंट्रल IIP. डॉक्टर रुपेश बच्छाव सर आहेत का? डॉक्टर योगेश साळुंके, आपण त्यांचा सत्कार करावा. यानंतर डॉक्टर निखिल पाठक सर, डॉक्टर कपिल देवांग आहे, आपण त्यांचा सत्कार करावा. डॉक्टर निखिल पाठक सरांचा आता सत्कार होतोय. डॉक्टर कपिल देवांग करतायत. यानंतर डॉक्टर शिरीष कांक्रिया सर, महाराष्ट्र EB. डॉक्टर सुदीप सिसोदे सर आहेत का? बर. डॉक्टर अभिजित भापणकर सरांचा सत्कार डॉक्टर सुधीर भदाणेंनी करावा. डॉक्टर सुचेता पोकळे मॅडम, डॉक्टर शशिकांत राणा आहेत. ममता पाटील मॅडमने त्यांचा सत्कार करावा. डॉक्टर सचिन वाहदणे सर, आहेत? डॉक्टर सुहास रोटे सर. त्यानंतर डॉक्टर प्रणोती जाधव मॅडम, एडिटर संकल्प बुलेटिनच्या, त्यांनी सगळं धुरा पाहिली. डॉक्टर पंकज अग्रवाल सर आलेले आहेत. हे व्हाईस प्रेसिडेंट आहेत महाराष्ट्र IIPचे. त्यांचा सत्कार सुद्धा डॉक्टर महेश अहिरराव सरांनी करावा अशी मी त्यांना विनंती करतो. मालविका कुलकर्णी मॅडम आहेत का? याच्यानंतर डॉक्टर प्रणोती जाधव मॅडम, त्यांचा सत्कार सुद्धा डॉक्टर ममता पाटील मॅडमने करावा. डॉक्टर ऋषी लोढया सर आहेत? या सर. संकल्पचं जे संकल्प जे काय ज्या पद्धतीने बुलेटिन तयार केलं त्याच्यामध्ये तुमचं सुद्धा फार मोठं कॉन्ट्रिब्युशन. या सर. आपला सुद्धा सत्कार डॉक्टर प्रदीप पाटील सर आले. डॉक्टर संजय जोशी सरांनी त्यांचा सत्कार करावा. याच्यानंतर आता मंचावर उपस्थित असलेल्या मान्यवरांचा आपण सत्कार करूया. डॉक्टर अतानु भद्रा सरांचा सत्कार डॉक्टर जगदीश पाखरे सरांनी करावा. अतानु भद्रा सर आपल्यासाठी खूप लांबून आले. We are truly honored to have him with us today. डॉक्टर ममता पाटील मॅडमचा सत्कार डॉक्टर नीता हटकर मॅडमने करावा. मगाशी डॉक्टर शिरीष कांक्रिया सरांचा सत्कार राहून गेला होता. सर आलेले सर, या मंचावर या. त्यांचा सत्कार डॉक्टर महेश अहिरराव सर करतील. यानंतर डॉक्टर संजय पाखमोडे सरांचा सत्कार डॉक्टर अभय कुलकर्णी सर करतील. यानंतर डॉक्टर संजय पाखमोडे सरांचा सत्कार होतोय. डॉक्टर अभय कुलकर्णी सर करणार आहे. यानंतर डॉक्टर अमोल पवार सरांचा सत्कार डॉक्टर दादाभाई करतील. यानंतर डॉक्टर रवींद्र सोनवणे सरांचा सत्कार डॉक्टर जयंत देवरे सर करतील. रवींद्र सर, डॉक्टर जयंत सर सुद्धा खूप छान गातात. तेवढ्यासाठीच म्हणून ठेवलेलं. यानंतर डॉक्टर संजय जोशी सरांचा सत्कार डॉक्टर सुनील पगारे सर करतील. आले डॉक्टर सचिन वाडणे सर राहून गेले होते. या 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 सर. हो, ते मीच सांगितलं होतं, माझीच चूक झाली. सर या. डॉक्टर महेश डॉक्टर पगारे सरच त्यांचा पण सत्कार करतील. डॉक्टर संजय जोशी सरांचा सत्कार डॉक्टर संजय जोशी सरांचा सत्कार डॉक्टर पगारे सर करतील. अरे द्या लवकर द्या, तयार राहा. वसईकर सर आहेत. डॉक्टर महेश अहिरराव सरांचा सत्कार डॉक्टर सुरेश वसईकर सर करतील. हो हो. डॉक्टर महेश अहिरराव सरांचा सत्कार डॉक्टर सुरेश वसईकर सर करतायत. यानंतर वा वा ही राम भरत गळा भेट होती का. यानंतर धुळे IIPचे अध्यक्ष, सतत हसत असणारे, आता सुद्धा स्टेजवर असणारे डॉक्टर तुषार कानडे सरांचा सत्कार डॉक्टर राजेश अग्रवाल सरांनी करावा. काल धुमाकूळ घातला तुम्ही दोघांनी पण. यानंतर राठी सर आहेत. पुरुषोत्तम राठी सर आहेत. डॉक्टर दादाभाईंचा सत्कार आपण डॉक्टर अविनाश सेंदाणे करतील. दोघं अगदी जवळचे मित्र आहेत. आता आणि मग गलाणी सर. यानंतर डॉक्टर नारायण गराणी सर, आमचे IIMचे प्रेसिडेंट, त्यांचा सुद्धा सत्कार डॉक्टर संजय जोशी सरांनी करावा असं मी त्यांना विनंती. हो. यानंतर डॉक्टर अविनाश सेंदाणे यांचा सुद्धा सत्कार आपण करणार आहोत. डॉक्टर अमोल पवार सरांनी त्यांचा सत्कार करावा. आपल्या धुळ्यामध्ये प्रॅक्टिसचे भीष्मपितामह असलेले काही सिनियर डॉक्टर्स होते. डॉक्टर आगीवाल सरांचं प्रतिनिधित्व जे करतायत ते आपले नितीन बंग सर सुद्धा इथे आलेले आहेत. तर त्यांचा सुद्धा सत्कार आपण करूया. या सर. त्यांचा सत्कार आदरणीय ममता पाटील मॅडमने करावा अशी मी मॅडमला विनंती करतो. या सभागृहामध्ये 85 वर्ष क्रॉस झाल्यानंतर सुद्धा प्रॅक्टिस तितक्याच उमेदीनं करणारे, तितकेच हसतमुख असलेले जळगाव IIPचे डॉक्टर चंद्रशेखर सिक्ची सर सुद्धा आलेले आहेत. त्यांचा सुद्धा सत्कार करणं हे आम्ही अत्यंत महत्त्वाचं मानतो. आणि सर मी डॉक्टर अतानु बद्रा सरांना विनंती करतो की त्यांनी त्यांचा सत्कार करावा.
आता आपल्या सर्वांचा लाडका अभिनय, आजचं सूत्रसंचालन त्याने अतिशय सुरेख अशा शब्दांमध्ये केलं. तर मी डॉक्टर संजय पाकमुडे सरांना विनंती करतो की आपल्या महाराष्ट्र IIPचा लाडका, धुळ्याचा लाडका आणि खानदेशचा लाडका अभिनयचा त्यांनी सत्कार करावा.
अतिशय सुरेल संकलन केलं, त्याचा आवाज इतका भारदस्त आणि ऐकतच राहावं असं वाटतंय असा हा अभिनय. आणि खरंच म्हणजे सरांनी मला आत्ताच सांगितलं की बऱ्याच मराठी सिरियल्समध्ये तो काम करतोय. सो सूत्रसंचालन एवढं चांगलं होतं की म्हणजे आज असं वाटलं की कोणी प्रोफेशनल व्यक्ती सूत्रसंचालन करतोय.
वेळ कमी होता म्हणून कंट्रोलमध्ये होतं, नाही तर आपण दोन तास सुद्धा बोर झालो नसतं. एवढं एक शेवटचा सत्कार आहे. मागे 2 वर्षापूर्वी महाराष्ट्र IIP आणि धुळे IIP असा एक जॉईंट प्रोग्राम डॉक्टर वाडिले सर, डॉक्टर दादाभाई पाटील, डॉक्टर संजय जोशी सर, महेश आयराव सर आणि पूर्ण टीम यांनी एक उपक्रम हाती घेतला कुपोषण निर्मूलनाचा. तर अतिशय सुरेख असा जो प्रोग्राम ऍक्टिव्हिटी होती, सोशल ऍक्टिव्हिटी, ती अतिशय चांगल्या पद्धतीने त्यांनी पार पाडली आणि आपला एक खारीचा वाटा त्यांनी कुपोषण निर्मूलनासाठी महाराष्ट्र IIP मध्ये छोटा ब्रांच, धुळे छोटी ब्रांच आहे आणि त्यांनी हा सर्वांना आदर्श घालून दिला. त्यातर्फे महाराष्ट्र IIP तर्फे संजय पाकमुडे सर, अटनू भद्रा सर आणि सर्वांना विनंती करतो की प्रातिनिधिक स्वरूपात मंचावरील जे धुळे IIP ची टीम आहे त्यांचा सत्कार करावा.
वाडिले सरांना विनंती करतो, त्याच्यानंतर राजेश अग्रवाल सरांना, पाखरे सरांना विनंती करतो, परीक्षित, कुणाल, जयंत देवरे सर, सगळ्यांनी या प्लीज. मिलिंद, योगेश, सचिन सर या ना. आता ते स्टेज पडू शकतो. मी उतरतो खाली. हे पडेल बरं का आता, हे खरंच पडेल आता. पूर्वी कॅमेरामनचं कसं असायचं की रोल संपला असं त्याला म्हणता यायचं, पण आता त्याला म्हणता येत नाही तसं, काढत राहायचे असतात फोटो. आय नाव रिक्वेस्ट डॉक्टर अतानू भद्रा सर टू से फ्यू वर्ड्स. आपले चीफ गेस्ट आहेत, आजचे प्रमुख पाहुणे आहेत आणि रसगुल्ला आहे म्हणजे सर खूप भालो.
So there is a famous saying that the future belongs to them who believe in their beauty of their dreams. So from yesterday, IIP Dhule branch has started dreaming a new dream that the Maharashtra Pedicon would be in Dhule. And I can promise you that if nothing untoward happens, I'll be there at that time also, along with Dr. Sanjay Pakmure and the whole Maha-IIP team here. So this power of the dream comes from teamwork, because individually we are all have limitations of power, but when we combine together, the teamwork there definitely is a power. And I saw that from the very seniors, from teachers, from students, everyone is a team in Dhule. So you have the power and capacity to reach your dreams. So thanks, though I cannot, the whole team had contributed to it, but still Dr. Tushar, Dr. Dadabhai Patil, Dr. Avinash, Dr. Sanjay, Dr. Mahesh, Dr. Yogesh, Dr. Obinay and Dr. Pakre, you will go, would keep the flag of Dhule flying and Maha-IIP flying high. And I know you will really have done a tremendous organizational work for these 2 days. thank you from Central IIP and from all parts of Maharashtra that you have contributed to their power. So you are there in the MahaIIP map, but now that would be glowing in that MahaIIP map. So the name of Dhule would be glowing. Thank you from yesterday. Yes, it was when I first heard about Khandesh few years ago, I had thought that Khandesh is very close to a Bengali word Sandesh, and that means sweet. So yes, these 1.5 days we are really overawed by your sweetness, your hospitality, and your work and team efforts. Splendid people. Please, we are there to help you to go ahead in front of in Indian Academy of Pediatrics. As I had been traveling in different branches of Indian Academy of Pediatrics from one state to another, I could understand the requirements and the demands of the branches are different. When I was in Andhra, they were different. When I was in Maharashtra, it was different. It's different. So we are trying to accumulate all these dreams, all these requirements, all these demands into Indian Academy of Pediatrics for the last 1.5 years, so that we can cater to all of you. I had given my contact number and email, but the email addresses, phone numbers, contact numbers are there. Please don't hesitate to send your suggestions, because whatever you say, it's your organization, and we will only go ahead if there are some changes coming in, and the changes will always be for the good. When Indian Academy of Pediatrics tries to think, we try to think in our meetings, there is a 80-member executive body team from all across the country, but the voices, actually they put the voices of all of you into the executive body. But even I would request all of you to contact any of us, any of your EB members, any of us, to give your suggestions and whatever we can do. The first thing I think for organization, and I would request IIP Dhule to look into it, is to have an office address. Because in many branches, we are now encouraging them to get their office addresses, a small building, a small apartment, and if Maharashtra Pedicon is held here, I think finance won't be a problem after that. So, because it's an identity of the organization. For the academics, Indian Academy of Pediatrics were already known for academics, but we are changing the system a bit. Rather than single speakers, we are trying to bring out the young talent. We are trying to bring out that they have the option of their careers. We have tied up with different universities outside the country, and we are trying to send some of those who are interested, young talented members, to do their courses in UK, USA, and just now we have tied up with an organization, USA-based organization, and we will be representing it in Budapest. So it's a whole lot of academic future for IIP members. So I would please encourage all the postgraduate students and the members to come up and actively participate in our in Indian Academy of Pediatric programs. The second major thing for the last 2 years that we had been doing is the community work, which IIP Dhule had already been doing. So please, I think whatever you are doing, please put it in the report. There is a system of reporting. I would ask the executive body members from Maharashtra to encourage IIP Dhule to put their work there, so that it is there in the website, and during the Pedicon the award is given to those branches who are doing community work. So I would like to see Dhule's name there in the Pedicon when we give these awards. Visit the social media, Twitter and handles. You can see a lot of work going across the country, all posted there. And you would love to see your leader's name, you would love to see your name there in those Twitter handles and social media handles. Join the WhatsApp channel, join the Facebook page, and I think you'd love to be, though Dr. Samir would not encourage going to the social media and spending more time on our mobiles, but still it has a role because IAP has an identity. Finally, yesterday also I had asked you a grand invitation to all of you to IAP's flagship program, the National Pedicon, which would be in Calcutta. This is an opportunity to thank all of your central EB members from Maharashtra who had been responsible for giving this Pedicon to Calcutta, actively participated and actively helped us to give this Pedicon to Calcutta. So please be there, it's your Pedicon. Whatever help you will need, my number, contact number is there, but you need not, whenever you want to approach us, Sanjay sir is there. So please see that Maharashtra gets the participation responsibility there. Finally, the origin of IAP was like this, that there were two small pediatric organizations. One was in Calcutta and another was in Mumbai. Two parts of the country. Then Dr. K.C. Chowdhury and Dr. Paul, they decided, combined together, and IAP was born. So if everything goes right, again in the majority of the OBs would be from these two parts of the country who actually had contributed for the birth and origin of IAP. So thank you once more for the splendid hospitality and thank you for this splendid conference. Thank you.
Thank you so much, sir. यानंतर डॉक्टर्स लिहितात पण, आणि ते लिहितात त्यावेळेला भरभरून लिहितात, आणि जेव्हा लिहितात त्यावेळेला महाराष्ट्रभरातून हे सगळे लेख ज्या वेळेला संपादित करण्याची जबाबदारी येते त्यावेळेला खऱ्या अर्थानं मजा येते. आता स्पंदन नावाचं आमचं जे बुलेटिन महाराष्ट्र IAPचं आहे त्याचं प्रकाशन सोहळा आता इथे होतोय. हा शेवटचा टप्पा आहे. याच्यानंतर आपल्याला जेवायला जायचं आहे. 20 मिनिटाचा जेवणाचं ब्रेक असणार आहे. इथे 5 पोस्टर्स लावलेले त्या पोस्टर्सचं परीक्षण सुद्धा याच्यानंतर होणार आहे. त्यामुळे भरपूर एक्साइटमेंट याच्यानंतर सुद्धा आहे. मी प्रणोती मॅडमला विनंती करतो, त्यांच्याबरोबर डॉक्टर ऋषी सुद्धा होते आणि या दोघांनी मिळून मेहनत केल्यामुळे या स्पंदनचं आता प्रकाशन या इथे स्टेजवर होतंय. याच बरोबर संकल्प आणि याच बरोबर धुळे खानदेशकॉनच्या तर्फे सुद्धा किंडर केअर नावाचं एक स्मरणिकेचं सुद्धा प्रकाशन यावेळेला होणार आहे. त्यासाठी सुद्धा ज्यांनी अतिशय कष्ट घेतले ते डॉक्टर विलास पाडीले सर सुद्धा आहेत. त्यांनी सुद्धा मंचावर यावं. या स्मरणिकेचं आता उद्घाटन होत आहे, प्रकाशन होत आहे. संकल्प प्रमुख पाहुण्यांच्या हस्ते संकल्प या बुलेटिनचं प्रकाशन सोहळा इथे पार पडतोय. टाळ्यांच्या गजरात आपण सगळ्यांनी स्वागत करूया. यानंतर खानदेशकॉनचं किंडर केअर नावाचं जे स्मरणिका आहे त्याचं सुद्धा पहिली वेळी स्मरणिका डॉक्टर्सने खूप छान छान लिहिलेलं आहे. ते नक्की वाचा. ती जी बॅग तुम्हाला मिळालेली त्या बॅगमध्ये आम्ही सगळ्यांना ते किंडर केअर देतो आहोत.
संकल्पसाठी मला डॉक्टर ऋषी लोढिया आणि डॉक्टर प्रणोती जाधव या लोकांनी अतिशय कमी वेळात हे आमचं मॅगझिन आहे जे अजून याचे म्हणजे हे आमचं मुखपत्र होतं. यावर्षी आम्ही ॲक्शन प्लॅनमध्ये घेतलेलं आणि अतिशय कमी वेळात आणि धुळे IAPने आम्हाला याच्यात बरीच मदत केली संकल्पला संघटित करायसाठी. तर त्यांचे मी आभार मानतोय. म्हणून एवढ्या कमी वेळात हे मिड टर्म CMEमध्ये आम्हाला हे करता आलं, सर्क्युलेट करता.
यानंतर किंडर केअर या स्मरणिकेचं प्रकाशन होत आहे. सर्व मान्यवरांचे मी आभार मानतो. प्रणोती मॅडम तुम्हाला काही बोलायचं असेल अगदी बोला, कारण कसं काय झालं.
Good evening everyone. Firstly, I am thankful to Dr. Sanjay Pakmode sir, Dr. Amol Pawar sir and Dr. Sanjay Deshmukh sir who gave me and Dr. Rishi Lodia sir the opportunity to be editors of Mahaiap Bulletin. So this year, I also want to acknowledge the hard work and efforts all our previous editors have put into the previous publications, like Runanubandha and Darpan. So this year, when we all sat for brainstorming as to what to do this year, we came up with the name of Sankalp. So Amol Pawar sir basically came with the name of Sankalp. It means belief or decision to do something. So it also resonates with all the pediatricians who are always trying to strive more, achieve more, and work more. Along with that, I'm also very thankful to the team of Dhule IP who have been effortlessly and seamlessly involved into designing and printing. So thank you so much, everyone. Thank you.
थँक्यू मॅडम. महाराष्ट्राच्या राजकारणात सुद्धा एक दादा लागतात आणि दादा कायमस्वरूपी कुठे ना कुठे असतात. तसं धुळ्याच्या सुद्धा या संपूर्ण सोहळ्यामध्ये एक दादा कायमस्वरूपी होते. त्या दादांना आता मी आमंत्रित करतो की त्यांनी आभार प्रदर्शन करून एकदाच लोकांना जेवणाकडे वाटचाल करण्यासाठी उद्युक्त करावं.
एक तास जेवण उशिरा झाल्यानंतर माझी अवस्था आता अशी झाली आहे, सकाळच्या कार्यक्रमामध्ये एक मांजर घुसलं होतं. हॉलला पण ते मांजर नको होतं आणि मांजरला पण हॉल नको होता. सेम परिस्थिती माझी झाली आहे. तरी पण आलेल्या पाहुण्यांचं स्वागत करणं आणि त्यांना थँक्स म्हणणं हे आपल्या परंपरेनुसार आहे. अरेंजिंग ए कॉन्फरन्स इज ए बिग चॅलेंजिंग टास्क. इट कॅनॉट बी possible without great presentation, wise working hand, support from every corner and blessing. It is now time to convey our gratitude to all who have extended support to make this event successful. On the behalf of Team IIP today, I extend heartily vote of thanks to our chief guest, Dr. Atanu Batra sir and Dr. Mamta madam, who spared their precious time and schedule to grace the occasion. Really thanks ma'am and sir also. Also the team Mahaiap support and give this conference to us. We thanks to Mahaiap. It is now our the chairperson Dr. Sanjay Joshi sir and Airav sir have taken the tremendous effort and to make this conference successfully. आणि मुद्दा म्हणून मराठी सांगतो की दोघं सरांनी आपल्या ज्युनियर सोबत कसं बिहेव केलं पाहिजे, त्यांना कसं प्रमोट केलं पाहिजे, त्यांना कसं प्रोत्साहन दिलं पाहिजे, ही सगळ्यात मोठी गोष्ट मी या दोन्ही आमच्या आयडॉलकडनं शिकलो आहे. खूप काही जास्त वेळ घेत नाही, मी माझं वोट ऑफ थँक्स थांबवतो आणि आता आपण लंचसाठी जाऊया. थँक्यू व्हेरी मच.
नंतर 20 मिनिटांनंतर आपल्याला पुन्हा एकदा हॉलमध्ये यायचं नाही, तसेच निघून जाल. पुढचे लेक्चर्स आहेत अजून. आल्यानंतर पोस्टर प्रेझेंटेशनच्या बक्षिसांचं सुद्धा अनाउन्समेंट होणार आहे. काय सुंदर आहे. एक ग्रुप फोटो घ्यायचा.